Hello? Hi. I never feel like I need a microphone in a room this big, but Joel will get mad at me if I don't speak into it. Hi, I'm Bob Megna. I'm president of the Rockefeller Institute. I want to welcome everyone here today and thank you for coming out in a global warming snowstorm that we have now. I think welcome. Again, thanks for coming, InUnity folks, and I hope you have a really good conference. I'm going to let you get started. I hate standing up here spewing out stuff when you have important information to learn, so I'm going to ask Sarah to come up and kick off the conference.
Good morning. I'm so happy to be here and grateful you could all join us this morning. First, I'll introduce myself and talk a little bit about InUnity Alliances. We're a newly formed organization. I'm hearing a little bit of echo. Are you hearing that as well? Okay. Let's see what I can do. Is that better?
I think so. Go ahead.
Okay. All right. So InUnity Alliance is a new organization formed by two long-standing associations, the Coalition for Behavioral Health and then the Alcoholism and Substance Abuse Providers Association of New York State. And together we now represent more than 200 community-based organizations across the care continuum. So you're talking any service related to prevention all the way through to vocational and job placement services. So the providers that we serve are diverse and they're also statewide. I want to make sure that I thank the Altman Foundation for funding this initiative, and also to the Rockefeller Institute for facilitating the writing of the white paper that Courtney Burke will discuss in just a few moments. And then also for the support that we received for the event today. I know that Rockefeller was unable to, they had one of their most valuable employees find a new opportunity, and so their team had to hustle. And so thank you very much to Heather Trella and others who made this possible. So this brings me next to the reason for the event today. For most, insurance holds the key to accessing any healthcare service. A number of the issues discussed today will go well beyond behavioral health. However, we're still wrestling with vestige regulations and practices born out of longstanding stigma. The powerful impacts of timely access to addiction and mental health care, its ability to dramatically change the course of a life, and the ripple effects throughout our communities are still not fully recognized. We know people can and do recover when they get care. We know that overdose deaths and suicide are preventable. We are also still grappling with persistent disparities in access to care among marginalized racial and ethnic groups, individuals who identify as LGBTQ+, people with disabilities, populations who are justice involved, and rural communities. In the wake of the murder of an insurance executive, the national conversation has centered around mounting frustration with the inability to access essential care. We recognize healthcare costs continue to rise. We are also collectively hearing from people seeking care and those who very much want to provide it. We know that the systems designed to guard against waste and increase quality are also unnecessarily blocking access to care. We know that the time for care professionals in severe shortage are being diverted away from direct care to complex administrative processes to get approval for the care provided. And we know that teams of staff, big teams of staff, are necessary to navigate it all. We are fortunate to live in a state that has taken the lead in closing the coverage gap and grateful for their leadership and partnership in improving access to care. Today we will discuss what has been done and opportunities moving forward. Courtney Burke will provide an overview of our white paper. We will hear then from the state's Ombudsman Program on access to SUD and mental health services, CHAMP. And then the state agencies will share what they are seeing and what they're doing. The New York State Office of Addiction Services and Supports and Office of Mental Health Commissioners will then provide a keynote address, and we'll have plenty of opportunity for discussion and questions. So that, I will hand the presentation over to Courtney Burke, who will talk about our paper.
Thanks, Sarah, and welcome everyone. It's great to see people in person. And now I'm seeing some people that I've seen on Zoom now that I'm standing up here that I've never met in person, so it's good to see you. I also know we have a number of people who are joining us virtually, so hopefully this will be an engaging conference today. We will be sticking with that agenda that Sarah just outlined. So on behalf of the Rockefeller Institute, welcome. I'm Courtney Burke. I'm a senior fellow in healthcare here. And we've been working with InUnity over the last couple months to highlight exactly what Sarah was outlining, which is the challenges to accessing behavioral health, specifically as it relates to insurance coverage. These types of forums are only made possible thanks to the staff at the Rockefeller Institute. So I know Sarah gave a shout out to Heather Trela. I also wanted to acknowledge Joel Tirado and Michelle Charbonneau, who also helped with organizing today. What I wanted to do today was talk about what we did in terms of putting the paper together, and many of you were able to get an actual copy, a paper copy. It seems so old-fashioned these days if you came here in person. But we did post the paper online for those who are participating with us virtually today. So this paper, we started out initially talking about, well, let's see what's happening around the country. So some of that research did end up in this paper. You'll notice that we don't just talk about New York, even though the conversation today is mostly focused on New York. But there are other states that we highlighted, like Pennsylvania, California, New Jersey, other ones that are doing some pretty interesting and progressive things in this area. And the paper, for those in the room, and I'm guessing for a lot of people online, isn't going to be a shocker to you. You've seen a lot of these issues, and in fact, many of you in your day jobs, for those who work for the state, have done some pretty amazing things to address it, and I actually consider many people in this audience to be more expert on the topic than myself. But it's really great when I started looking across the various states and saw how much New York was doing. That said, there's still opportunities to improve access to behavioral health services as it relates to insurance coverage. So some of the things that we highlight in the paper that I'll go over briefly here, first of all, it's just eligibility for insurance to begin with. We take that for granted, I think, many times because at one point in time, insurance coverage was a major issue. I don't know if people remember this thing called the Affordable Care Act, but you had uninsured rates at nearly 2 to 3 times what they are today. So people weren't even getting access to basic insurance 10 years ago. Now that we have it, there are still populations that don't have equal access, and New York has taken some steps to address that. Certainly looking at coverage for inmates, looking at immigration status and how to better provide services to whether it's people residing here under color of law or what are known as the Dreamers, the DACA population. So those are some areas where there have been recent expansions to improve access to insurance to begin with. The second area that the paper focuses on is looking at mental health parity. And this has been an issue for well over a decade when at the federal level, the Mental Health Parity and Addiction Equality Act, MAPIA, some people refer to it, when that passed, but we also had Timothy's Law here in New York State. And even with those laws, there's still opportunity to improve parity. There are populations and different conditions that are not covered under that legislation, and then enforcement of it has been difficult, particularly if there's issues with not covering things equally like telehealth services or not paying for those services. So a lot of opportunity there as well to continue to close that gap. Another issue, of course, is affordability, and that's an issue in healthcare generally. But we've seen the emergence and the growth of high deductible health plans where the consumer ends up paying more out of pocket, and a lot of times they can't afford to pay that, and therefore they go without the coverage or they delay the coverage. And that can be particularly detrimental for somebody who has a behavioral health need. And so figuring out ways to close those gaps is another thing that's examined in this paper. A third thing is the administrative barriers that the consumer can run into when trying to access services. Although I understand the role of pre-authorization and looking at what types of services are appropriate or not, for somebody who has behavioral health needs, that can be an incredible barrier to have to go through that approval process because you really need that timely access. So how do we simplify the pre-authorization process, and how do we minimize or make it more efficient and effective in the future? So the paper also talks about that. There are a lot of issues too with the network adequacy. Do you have the right kinds of providers in your network? And if you have them, does the consumer have up-to-date information about where they can access those providers? But then if they have the up-to-date information, how long is it going to take them to either get there physically? Are they going to have to drive 2 hours? Are they going to have to wait 5 months? Again, time is of the essence if somebody has a behavioral health need. So putting requirements or at least minimum standards around that network adequacy, what should be expected in terms of keeping the provider directory up to date, what should be expected in terms of commute time or wait time for appointments, again, is also something that's covered. And then when a claim is denied, what is the process for appealing that denial? And consumers don't always have great access to information of how that works, and there can be many different hoops for them to do that. So how do we make that process simpler for people so that if the denial happens, there isn't a way for them to challenge that more readily than they might be able to right now? And of course, how much we pay behavioral health care providers can also impact if networks are adequate and whether different providers are going to participate in different programs depending on what they're getting paid for that. And then there's always things that can happen with people's in their lives where they have disruptions to their insurance and they don't have timely access. So these are all things that are addressed in the report. I think one of the important things to remember as we're thinking about all of this is not a comprehensive paper. We tried to be as comprehensive as we could. We plan to issue an addendum to this paper online that talks about the disproportionate impact for various populations who may not have ready access to behavioral health care. And that's an important area where there's still a lot of room for improvement. There are other things that could be looked at that could improve care. And so, maybe there's a part 2 to this conversation, and maybe we'll get into a little bit more of that with the great panel that we have this morning. One of the things I just want to emphasize before, and I don't know if Karla is here yet. Oh, good, you are. Okay, great. Before I introduce Karla, is just the urgency and importance of this problem. A third of adults experienced a behavioral health condition in 2022, and 1 out of 5 kids between the ages of 12 and 17 reported having a major depressive episode in 2022. So this is really an important issue. We have not always treated behavioral health on par with other health, and it's time that we begin to do that. And I think that this paper helps outlines the opportunities for us to do so. So one of the innovative things that New York State has done was establish a program called Community Health Access to Addiction and Mental Health Care Project, which is really designed to help consumers access and navigate behavioral health services. And we're very happy that today we are joined by the supervising attorney for that program. And I know many people in this room are very familiar with it. So Karla Lopez, so it is my pleasure to introduce Karla. So as I said, she's the supervising attorney of what's called the CHAMP program. She led the launch of CHAMP in 2018 and manages its staff in a network of different partner organizations across the state. It is actually housed at the Community Service Society. So prior to joining CSS, Karla was a senior staff attorney at the Legal Action Center, a not-for-profit law and policy organization that fights discrimination against people with substance use disorders, HIV/AIDS, criminal records, and so on. She has written and trained widely on laws requiring parity in substance use disorder and mental health. And she has a BA from Bard and a JD from Georgetown University Law. So very happy to have you, Karla. Come on up.
Hi, everybody. Oh, there we go. Thank you for having me. It's so nice to be here and see so many familiar faces in person. I have some slides. I have about 15 minutes to talk about CHAMP, which is New York statewide ombudsman program, helping people overcome health insurance barriers to substance use disorder and mental health care. Are you able to pull up the slides? Do I need to do something? Let's see. I can also just start. Okay, I'll start while the slides go up because I know we're on a somewhat tight schedule. So I'm Karla Lopez. I am the supervising attorney of CHAMP. There we go. And I work at the Community Service Society of New York down in New York City, which operates CHAMP, as Courtney said. And our project director, Ryan Gallagher, is also here from OASIS and OMH. And just a little bit of the history about CHAMP. So we were created by state statute in 2018, and we are funded and overseen by OASIS in consultation with the Office for Mental Health. And the reason that CHAMP was created, why this ombudsman program was created, is because of the history that I think so many of us are familiar with of how difficult it is to get health insurers to cover mental health and addiction care relative to other types of health care. And although the federal and state governments have passed a number of laws, including the federal parity law and all the wonderful state statutes that have been passed over the past decade plus, we were really seeing that a lot of people in New York didn't know that they had those rights. They didn't know how to enforce those rights. And they were still running into barriers, the kinds of barriers that these laws were meant to prohibit. So we created CHAMP to help consumers and providers understand their rights, enforce their rights, and get their health insurance to pay for substance use and mental health care. So we really do, the work that we do for our clients runs the gamut. Any barrier, any insurance barrier to substance use and mental health care, whether that's just helping somebody find an in-network provider, to helping them figure out what to do if there is no in-network provider, whether that's requesting an out-of-network referral, filing a complaint. We help people with denials of care. We will file appeals with health insurers. We'll file external appeals. We help people who are uninsured with enrolling in coverage, or people who are underinsured determine if they're eligible for additional coverage. And we look out for potential violations of the parity law, which I think folks are familiar with, but which requires relatively equal coverage of mental health and substance use disorder care by health insurers as compared to what's called medical or surgical care. So we do look out for potential violations of parity and other laws, and we file complaints with regulators when we see them. So we run a live answer helpline, which I'll talk about a little bit more in a minute, but our services are free, they're confidential. We help people with any type of health insurance, including people who are uninsured, and we serve the entire state of New York. So the way that CHAMP is structured is that the Community Service Society, where I work, subcontracts with OASIS and OMH to operate CHAMP. We run our live answer helpline. We partner with 3 specialist organizations, Legal Action Center, Medicare Rights Center, and the New York State Council for Community Behavioral Health Care, which provide expertise to the program. And then we have 9 community-based organizations that serve different parts of the state by directly helping clients in their communities on the ground. So people can call the helpline that's run through CSS for help anywhere in the state, or they can go to their local community-based organization and get help in person there. We pulled a couple of, I'm going to skip this one because I think OASIS is going to address it later. We pulled a couple of data points from what we've seen since we launched in 2017. This slide shows the type of insurance that our clients have and what they are coming to us for help with, which type of healthcare, substance use, mental health, or co-occurring disorders, co-occurring mental health and substance use disorders. And what we think is striking about this data is that you can see that in the commercial insurance realm, there's really a significant overrepresentation of people who need help accessing mental health care. And then in the other types of insurance, it's pretty evenly divided between mental health and substance use, and then we have a smaller portion of co-occurring. And then this slide here is just a quick pull of our last fiscal year, so 2023 to 2024, when we did file complaints on behalf of clients. What were the basis of those complaints? So the most common reason for complaints that we filed last year was issues with network adequacy. I think this might not be totally up to date. I think the second one actually was parity. And then we had a number of complaints around provider directory errors, as well as deficient denial notices. So that might be a denial notice that gives boilerplate language that doesn't really explain the reason for the denial or is in some other way deficient. A lot of complaints about misinformation, aside from misinformation related to provider directories, and then issues with payment for out-of-network care. And Sarah, if I'm starting to run close on time, just let me know. So I also just pulled a couple of the bigger systemic issues that we see in CHAMP to talk about a little bit before, I know a bunch of our wonderful state partners are going to be talking about their work. So this is just some of what we're seeing on the ground with our clients over the past 6-7 years. So of course, we are seeing issues with inadequate networks and provider directory misinformation. That can be anything from not having any providers in the network who are accepting new patients, long wait times, no providers nearby, no providers at all of a certain type. So I have a case example here where I'll talk about that a little bit more, but we see that a lot, particularly in commercial insurance with residential mental health care. And then, of course, there's the providers who are listed as being in network but are not actually in network or are not returning calls. So many barriers to accessing care in networks, as we all know very well. So a quick case example from CHAMP was, these are, of course, not our clients' real names, but we had a client who we will call Tanya, who had a fully insured employer-sponsored plan and contacted CHAMP for help finding treatment for her young adult son, who we are calling Andy. Andy had obsessive compulsive disorder and needed exposure and response prevention therapy, ERP. And Tanya had asked her health plan for a list of ERP providers within a 30-mile radius of where they lived who could treat her son. But when she called them, she found that the list they gave her was riddled with errors of all sorts, and none of the providers on the list were able to treat her son. And at that point, she contacted CHAMP. So CHAMP helped her file an out-of-network referral request with her plan. In the meantime, because her son was deteriorating pretty severely, she started paying out of pocket for him to see an out-of-network ERP provider. The plan denied their request for an out-of-network referral, and in the denial listed several providers in network who it said could treat his condition, and mom called all the providers. None of them were accepting new patients. So CHAMP helped them appeal the plan's denial, and the plan actually reversed its denial. Usually we have to go all the way to that external appeal to get to a reversal, but the plan did reverse its denial and agreed to cover the out-of-network provider for this client. By that point, Tanya had already spent $6,000 out of pocket for his care, and so she will be reimbursed that amount now, but of course, most people aren't able to spend that kind of money out of pocket while waiting for a process like this to unfold. We also see a lot of misapplication of clinical criteria and the use of inappropriate clinical criteria in medical necessity denials. We are so lucky in New York that we have state laws that require plans that are governed by New York State to use evidence-based criteria. So on the substance use side, plans and providers are required to use locator. On the mental health side, they are required to have criteria that meets certain standards and is approved by the Office of Mental Health. But of course, this does only apply to state-regulated plans, so all of our self-insured employer plans are not subject to these laws and can kind of do whatever they want to some extent. And then for plans who are using the appropriate criteria like locator, we see them misapplying it. So sometimes they'll ignore what's in the medical records and say, oh, this person only meets, one piece of the locator criteria. They have a mild substance use disorder, and they require SBIRT, screening, brief intervention, referral for treatment. And when we look at the medical records, and when the provider looks at the medical records, we see that they meet 11 criteria, and they have a severe substance use disorder that indicates the need for a much higher level of treatment. In the mental health side of things, we often see that plans will still deny treatment at a higher level, like inpatient or residential, if the person is not at risk of harm to themselves or others, when that's not actually consistent with evidence-based criteria. There are other factors that are supposed to be considered that we often see being ignored. And then again, we see that boilerplate denial language where they'll just say, the patient is improving without anything, being referenced that would support that kind of a conclusion. Another issue that a lot of CHAMP clients run into is the Medicaid Restricted Recipient Program. So this is a state program whereby Medicaid flags people based on their utilization of healthcare as potentially utilizing healthcare in a way that's excessive, duplicative, contraindicated, or conflicted. And because the folks who we serve, people with substance use disorders and mental health conditions, are often high utilizers of healthcare, whether that's like repeated treatment episodes or taking a lot of prescriptions or taking medications that are highly regulated because they are benzodiazepines or opioid agonists. We see them getting tangled up in the restricted recipient program and often don't realize it until the restriction has already been put into place. And once somebody's in the program, they're restricted to receiving their care from one hospital, one PCP, and one pharmacy. And if they need any other type of care, they have to go to that restricted PCP and get a referral. And of course, a lot of mental health and substance use disorder care is not received from a hospital or a PCP. It's a outpatient provider, an inpatient provider, a residential provider. And so when folks are trying to go get that type of care, they suddenly discover that they can't. They're in this restricted program. They don't know how to navigate it. So we spend a fair amount of time helping people kind of navigate these restrictions and hopefully getting them past that barrier before they change their mind or give up or relapse or become unreachable, because many of them are unhoused. And then the last thing I wanted to flag was administrative hurdles. So this is really like the gamut. I don't know if people have been following, ProPublica has been doing this series of articles on health insurance coverage for mental health and substance use disorder care. And one of the first ones was called Why I Left the Network. And it did a really good job, I think, of explaining what it's like for providers when trying to deal with insurance companies. And it's a lot of this stuff that's hard to, I think in a lot of ways, hard to regulate, hard to address, but it is kind of the death by a thousand cuts, and one of the reasons that so many providers, I think, do leave the network. But this can look like plans saying that they didn't receive claims or appeals or other documents that clients or providers sent. We've been seeing one plan in particular that clients will submit a claim for reimbursement. They never hear anything. They call the plan and they say what's going on, and the plan says, oh, we never received it, even if the person has, proof of receipt. So they send it again, and the same thing happens, and then they send it again, and then finally the plan says, oh yeah, we received it, but now we're denying your claim because it's been more than 180 days since you received the service, so it's too late. Even though, like, when they initially sent it, it was within the time frame that was required. So, that kind of administrative barrier, I guess we'll call it for lack of a better word. We see a lot of difficulty with out-of-network reimbursement rates, which is a big problem for our folks because, as we know, people have to go out-of-network for mental health and substance use disorder care at much, much higher rates than they do for other types of health care. So this looks like a lot of different things, but one of the things we have seen is commercial plans will say, we set our out-of-network reimbursement rates based on the Medicare rate. But they'll say that even for things where there is no Medicare rate, like residential treatment or applied behavior analysis. And then when you push them, you can't get an answer on how they're setting their rates. We've seen prohibitively long call wait times. You know, sometimes it takes hours to reach a plan. And if you have to call and call and call, you know, people give up. And that's kind of, that's one of the ways they kind of get you. Deficient denial notices, as I mentioned, whether it's the boilerplate denial language or, you know, totally omitting required language that tells people about their rights. Failure to provide required information upon request. That could be clinical criteria used in a denial. That could be a plan's parity analysis, which they are required by law to provide. And then in particular, we've been tracking some of the United Healthcare, I think they would frame it as kind of like fraud, waste, and abuse prevention. So they have something called the Program and Network Integrity Department that we've been tracking since the early days of CHAMP. It is a department within UHC that flags mental health claims in particular for, well, behavioral health, but we see it mostly in mental health, for potential fraud, waste, and abuse based on utilization. Our research over the years has never found a comparable department or function on the medical surgical side. They only do this on the behavioral health side from what we can see. We have filed a complaint with the Department of Labor about this. We will be filing complaints with the Attorney General about this because we have a bunch of these cases right now. And in our opinion, this violates the parity law because we don't see a similar department or action on the medical surgical side. On the medical surgical side, they wait for reports of potential fraud, waste, and abuse, where on the behavioral health side, they go out and proactively look for them. And then as part of this P&I department, we've been seeing more of what's called a prepayment review, where United will send, /Optum, which is administers their behavioral health claims, will send letters to mental health providers saying you're in a prepayment review and none of your claims will be paid until you submit a whole bunch of information for us. And from what we hear, we've seen these letters for years, but there seems to be an uptick in the past few months. A lot of these letters going out and people are just kind of at their wits' end, and their reimbursements are being held up or denied. Their providers are throwing up their hands and just saying, like, I don't even know what to send anymore to help you get reimbursed. So these are some of the administrative hurdles that we see. And this is our helpline number. We are open 5 days a week, 9 to 7, Monday, Tuesday, Wednesday, 9 to 5, Thursday, Friday. Our email address. Thank you so much. Sorry I was moving so fast there, but really looking forward to hearing our panel. Thank you.
Thank you, Karla. We're so glad that we could hear from CHAMP during this presentation, and I know it's tough through, for travel, especially on a day like this. So right now, what I'll be doing is introducing our panelists, comprised of state agencies. And earlier I mentioned that New York State has really been a lead in the area of behavioral health parity. And it doesn't take just high-level policy to get these across the finish line. And I've had the opportunity to work with a number of the panelists through the course of the past few years. And these people are very passionate and driven and care deeply about these issues. And without them, it's a good chance that maybe we wouldn't be as far along as we are. And so what I'll do now is ask our panelists to come up, and then I will provide the introductions. During this panel, the panelists will talk about what they're seeing from their vantage points, and then also what they're doing. So to begin, we have Joe Katagiri. Are we okay? I think so. All right, Joe is a deputy commissioner and now the chief fiscal officer at the Office of Mental Health. Prior to this role, he served as an associate commissioner for managed care and the bureau director of finance and data analytics, both at OMH. Before that, Joe served as a team leader for long-term care within the New York State Division of Budget and a health program administrator for the Department of Health, working on long-term care Medicaid waiver programs. We also have Tricia Allen. Tricia is the general counsel for the New York State Office of Addiction Services and Supports, or OASIS. Before her appointment as general counsel, she served as an OASIS senior and associate attorney. And prior to her time at OASIS, she was a legislative counsel for the Legislative Commission on Rural Resources. We also have Tricia Shelgai. Tricia is the Director of the Division of Program Development and Management within the Office of Health Insurance Programs at the New York State Department of Health. Prior to this role, she worked for over 14 years at Oasis and concluded her time as General Counsel. We also have Michael Reisman. Michael has been an Assistant Attorney General at the New York Attorney General's Healthcare Bureau since 2012. He has led numerous behavioral health parity settlements with health insurers that resulted in improved access to treatment and returned tens of millions of dollars to consumers. He was also a key member of the Attorney General's victorious trial team against the pharmaceutical opioid manufacturers and distributors over their role in the opioid epidemic. Before joining the Attorney General's office, he was a litigator at a large law firm where he led high-profile pro bono cases that improved the lives of mental health patients. Prior to becoming a lawyer, he was a mental health counselor and drama therapist in California, New York, and Czechia, thank you. Czech Republic. And I understand that he has also just come back from a recent humanitarian mission where he was continuing to provide some of these therapies during that time. So I thought I would throw that out because it's a case of interest. And I provided a longer bio than normal and what you typically see in a panelist group like this, because I feel like they don't get as much of, kind of the exposure that they very truly deserve. So thank you very much for joining us. And I will turn the presentation over to David Lloyd, who will be moderating this session. And I'll also give his bio. David is the Chief Policy Officer at Inseparable. David was previously Chief Policy Officer at the Kennedy Forum, where he led successful state and policy initiatives, including the enactment of nation-leading insurance legislation in California and federal legislation that ended the ability of state and local governments to discriminate against their employees seeking mental health coverage. He's also spent a considerable amount of time at the federal level with the U.S. Senate. Thank you, David.
Well, thank you. I'm David Lloyd, Chief Policy Officer at Inseparable, and really appreciate today's event. It's really important and couldn't come at a more important time. And thank you particularly Sarah and Karla for all your work, and as well as to the InUnity Alliance and Rockefeller Center for hosting today's important event. So just a little bit of introduction about Inseparable. We were founded in 2020 and are a national mental health policy organization that works across the country, including increasingly in New York, to ensure a future where mental health policy is no longer an afterthought and helps make our country thrive. And a top priority is increasing access to coverage, access to care through coverage reform. And thankfully, all of these panelists are already showing what is possible when state lawmakers prioritize access to mental health and substance use disorder care. And I very much look forward to a robust discussion of how we can continue to close the coverage gap in New York, which I'm now proud to call my adopted state. So let's get started. So Joe, I think we're gonna start with you. I've been working on mental health parity for a number of years now, and from early on, it's become clear that the Office of Mental Health was prioritizing these issues in a way that essentially no one else in the country really was. And critically, OMH has been coordinating with other state agencies in a way that's really unique across the country. And even today, this work stands above what's happening in other states. So can you just start us off by discussing how the Hochul administration and the Office of Mental Health are working to increase access to mental health and addiction care?
Yeah, so I wanted to talk about very quickly, and I think we already heard from Karla and Champ, which are the experts, obviously, but I wanted to talk about quickly what the individual impacts that we're seeing from restricted access to care than on providers, and then I was going to wrap it up quickly with what we're doing. So I'll be as quick as possible. There's a lot to talk about, but it's obvious that individuals often have an incredibly hard time accessing care. They may be denied upfront by their insurance company, be on the hook for large medical bills, or be unable to find an in-network provider that will see them. So a shared experience when you work for the Office of Mental Health from staff to the commissioner is that when you're out and about in your everyday life and you're doing something and someone says, hey, what do you do? Where do you work? And you tell them, oh, I work for the Office of Mental Health. And then inevitably they say, oh, I'm having issues and I can't find a provider to serve me, and I can't find the mental health services I need, or my spouse or my child, need these services and we can't find them. And so we hear that, and we have staff come back every day and saying we need to help this person, and we do. We one-offs, we help everybody, and we also take that information and we try to turn it into systems level change so that people aren't put in that position to begin with. But I would, to recognize from what OMH is seeing from an individual perspective, it would be access to care and affordability of care. And we know that, the reports that we've seen and all the information that we've seen, the report last year from the AG on network adequacy, that, when someone tries to access care and they have health insurance and they're looking it up, I think, Karla gave a great example of the individual's typical experience in going to a provider network and not seeing updated information or accurate information or timely information, and that's been hurting individuals and their families for some time, and I think that's something that we should be discussing more today. And then to shift to the impact to providers, who ultimately pays for appropriately delivered and needed mental health services has been a large problem in New York State. Oftentimes, providers that are left on the hook to cover the cost of care that it was again, appropriately provided. So starting in 2015, New York State carved many behavioral health services into Medicaid managed care. And after we did our readiness review and we had a startup period, OMH began monitoring and analyzing claims payment data that Medicaid managed care insurers submit to us. And we were also at the same time getting a lot of complaints from our provider system saying we're not getting reimbursed for the services that we are rendering. So what OMH observed was extremely high administrative denial rates for our OMH licensed services. Some of these services were being administratively denied at a 90% rate. So OMH and DOH collaborated quickly to correct the problems that we were seeing, and we issued 50 citations against 7 Medicaid MCOs. And we followed that long process through with repeat citations, and it culminated in $2.6 million worth of fines for 5 Medicaid MCOs for unacceptable denial rates and failure to pay mandated rate levels that the government requires. So from there, this is a long and arduous path of monitoring and overseeing and calling out the problems that we're seeing, verifying those problems, and then taking action. OMH and DOH, we've continued to monitor those problems, and since the $2.6 million in fines that took place between 2019 and 2021, we've issued 12 more citations for these issues, which now include insurers inappropriately not passing on some of the emergency ARPA funds which were intended for COVID relief efforts. So we have citations and fines against Medicaid insurers for their high administrative denial rates and for failure to pay mandated government rates. And on top of that, beginning in 2017, and everything I'm talking about is from the mental health care perspective, we started thoroughly examining the Medicaid managed care program in New York State for compliance with the Mental Health Parity and Addiction Equity Act, or MAPIA. And we took parity compliance and testing very seriously. We had conversations with national experts and tried to decide how we were going to tackle this and do the oversight and monitoring and enforcement, because it's a very complicated exercise. So we looked at all of the necessary things that you need to look at when you're looking at parity compliance, which are financial requirements, quantitative treatment limitations, and we looked at all 19 non-quantitative treatment limitation categories. We started by reviewing our own Medicaid managed care model contract for potential violations of MAPIA, and where we found anything that may be non-compliant, we removed that restriction, or we turned it into a soft limit, which would allow somebody to exceed that limitation when medically justified. So once we looked at our own model contract with the Medicaid insurers, we moved to performing as-written surveys of each Medicaid managed care MCO. And from there, we produced a report that's on the DOH and OMH websites, and it identifies 95 citations that we issued for non-compliance with MAPIA. And all these citations weren't necessarily for the insurer restricting access to care more stringently for behavioral health and physical health, but they were instances, definitely at minimum, where they were found to not be able to demonstrate that they were doing things in a parity compliant way. So that's the as written. component of it. And since then, you know, the movement after you look at as written compliance for parity, and those 95 citations resulted in $1 million worth of fines. We graduate to in-operation examinations because the as-written test is just merely a writing. You know, you write something down, you submit it, and we review that, and then we have the conversation and move forward. But an operation is preparing the data and showing evidence that what you're submitting is actually accurate. So we moved forward with another 55 citations, bringing our parity compliance related efforts to 151 citations against Medicaid managed care insurers since 2017. So that's a quick, very quick and dense overview of the actions and the things that OMH has been seeing and doing in this space and trying to free up access to care and trying to solve the MAPIA problem. But specifically, there are several things that we have done, which is we prohibit prior authorization for certain OMH services. We have rate mandates for OMH licensed services in school-based mental health clinics, and not only do we have them in the Medicaid plan, but we have them in commercial rates as well now. There was a new legislation passed last year, Part AA, that now requires Medicaid as the floor for OMH licensed services. Then I think many people have already talked about it, is the new network adequacy regulations that are going to be huge in New York State because they're moving from counts of providers in a geographic area to wait time standards. So it's not about how many providers are available around you, it's about how quickly you can get into the services that you or your family needs. And then Karla did talk about the medical necessity criteria review and responsibility that OMH has, where for New York State regulated plans, we have the ability and responsibility to collect their medical necessity criteria and make sure that they're not rounding against patients that need the care. And we have clinical experts that review and approve those all the time. And then the last thing we do, which is what I already mentioned, is active and ongoing MAPIA compliance efforts, and we're enforcing as best we can, and we are continuing to keep our eye on the ball when it comes to that. So that's where I'll stop.
Great. Well, thanks, Joe. That's
Sorry.
it's really a tremendous amount of work, and the in-operation parity compliance is so critical, as well as moving to wait time standards. I think is really important. So, Tricia Allen, we'll now turn to you and the work of OASIS. One of the policy areas that I've been working a lot on is criteria, and OASIS already has the locator tool that was developed with Columbia University. And we work on high quality criteria like the ACM criteria nationwide. So I'd love to learn more about OASIS's work and how you are prioritizing increasing access to addiction treatment.
Okay, just checking. So I'm gonna kind of reverse the order that Joe did, and I do apologize if some of this may sound repetitive, but I hope what you're getting from that is that we as the state agencies are working together intensively on this issue. So I remember back in 2010 when I was an intern with OASIS, hearing about providers being concerned about the way that claims were being paid or not paid. There were a lot of struggles that patients were facing when they were trying to get access to care. And over the course of the last, 10, 15 years, we've worked to do a couple of things. The first is to kind of set the floor for coverage. So I think New York State is a leader in this case for both mental health and addiction services. So what are we doing? We're defining what has to be covered. We're defining how it has to be covered. So this includes protections we've put in place for bedded and outpatient services, for addiction where there's no prior authorization and there's a time period where there would not be a concurrent review. I believe it's currently 28 days. In addition to that, as he mentioned, we have set a standard for how appropriateness is determined. So when people are going to the front door, what is the criteria that people are using to make that decision? So at OASIS, we implemented something called the locator tool, and this is a needs and resource evaluation that our providers do that decides whether or not a patient is appropriate to that level of care. That same tool is required to be used by New York State regulated plans in both the private and the public sector. So we're having people speaking the same language. We, as we've mentioned, have set reimbursement requirements, so Part AA for commercial payers, and then defining the reimbursement rates for Medicaid services. We've also implemented reporting requirements. So this is making sure that plans are identifying and documenting what care they're providing, and when there's any sort of appeal or denial, that there's some sort of documentation that they're providing saying what's happening there. We also have initiated the Ombuds program, so that is a shared initiative between OMH and OASIS, which allows for people who are experiencing problems to reach out and find somebody who can provide them with assistance. Because what I will say, I hear over and over again, is the biggest obstacle now that we've kind of unblocked the front door is understanding what your insurance coverage is. What does it mean? What kind of plan do you have? Is it subject to New York State law, or is it something that's regulated under ERISA? Do they have to provide you with outpatient services? How long do they have to provide you with outpatient services? Who's in network? Who's not in network? So I think that, especially for the patients, and I think this breeds a lot of frustration in a time in their life when they are struggling with something that feels like an emergency, is, you know, I don't know who I'm supposed to go talk to. I don't know what they're going to cover. I just want to get better. So we've focused a lot on trying to make information available to patients in terms of, you know, brochures, or, you know, simple things that they can look at to figure out what is their insurance company going to pay for. We've also worked with our state partners at DOH and at DFS to make model contract language for the commercial insurance companies that are covered by New York State law, to make sure that there is a simple document that a patient can look at to see what's actually covered under their policy. And then, you know, likewise, we have model contract language that applies to the Medicaid system. From the provider perspective, I do think, you know, similar to what Joe has mentioned, and I will assume Tricia will mention too, there is a workforce crisis right now. So we do have providers who are using their staff time to make sure that they're interacting with the payers and providing them with sufficient information to reimburse the services that are provided, because the law, the way that it's written for New York State for in-network providers, is that there is no prior authorization, there is no concurrent review for a period of time, but there is a retrospective review. So the providers are making sure that they're crossing all their I's, dotting all their T's, so they're doing the initial notification to the payers, but, you know, providing sufficient documentation to the plan to ensure that they're comfortable, appropriate services were provided, can take a significant amount of staff time. And when you don't have a workforce, that can be an extra burden. So that, I would say, is one of the things that we hear about often. So how is OASIS working to help? So obviously we are working with OMH on parity compliance reviews. We also do evaluations of plans, comprehensive and targeted plan surveys. So we go into managed care plans, we review the documentation that they have, we review the cases that they have in their system to see, are they following the rules? Are they, you know, using the appropriate medical criteria? And we will document and discuss that with the plans and educate them on what the appropriate thing is to do. Other things that we are looking to do in addition to the existing feedback loops. So we have the CHAMP program. We have innumerable mailboxes at OMH and OASIS for people to report issues as they're coming up. And then we are also working on having more comprehensive trainings available to providers. You know, as we have all of this staff turnover, it's really important that the provider staff understand how to interact with the plans and what is going to be, you know, the appropriate way to bill for something and be successful in getting reimbursed. And then we are currently working on increasing feedback loops. So in addition to the mailboxes, which I know can be frustrating, you know, because there's always this, we need an answer now. You know, we're trying to ensure that there are other feedback avenues and loops that people can utilize to reach out to the, you know, regulating agency, so OMH or OASIS, in addition to the existing complaints pathways that are available for through DOH or DFS. So that is what I think is less repeated.
Well, thank you, Tricia. And I really liked how you broke it down, what is covered, is it medically necessary, is it appropriate, and making sure that people can find access to care. Because at the end of the day, this isn't so complicated. Mental health parity is very complicated, but the basics of what people need, are not. So, Tricia Shalgai, we'll move on to you and the work of the Department of Health, which obviously has wide-ranging responsibilities over the state's Medicaid program, as well as New York State of Health, the state's individual marketplace. And of course, nearly 7 million New Yorkers, nearly 1 in 3 are enrolled in Medicaid or CHIP. So how is DOH prioritizing closing the coverage gap for mental health and substance use disorder care?
Great. So I will try not to be repetitive. We did try to work that out beforehand a little bit. From the DOH perspective, we absolutely know that access to behavioral health is critical. We know that that receiving specialty services, all specialty services right now, is difficult, including behavioral health, especially when we're talking about more complex or marginalized populations, even harder. We know that almost 40% of the Medicaid population has a behavioral health diagnosis, so either mental health or SUD, and as was said, there's about 7 million people in Medicaid, so that's 2.8 million people in the Medicaid program that need behavioral health services. In the Essential Plan, we have 1.6 enrollees, and about 500,000 of those folks need mental health and SUD services. And for qualified health plans, it's about 595,000 of the 1.7 million enrollees. We didn't even talk about commercial plans, right? And you saw Karla's slides, right? There's a need and a lot of people that aren't getting them. So, to T's point, we also know, and we're hearing in every sector, I think, including state government, right? We can't get staff. And in the behavioral health fields, it's difficult to get staff, or if they have staff, staffing turnover is really an issue. I was just at a conference with a group of kids, foster care children, really moving, who essentially said it isn't that they don't have people there that can provide them some mental health services, it's never the same person, and they never get to pick who their therapist is, right? And so there's this real inability to develop a relationship. So beyond just not having adequate staff, you don't have staff that's staying, right? So to that end at the department, we're trying to do things. We recognize that there are populations that need to have more staff available for their services. So we've got our New York Health Equity Reform Waiver, which I'm sure everybody here has heard us talk about umpteen times, but in that there's specific workforce initiatives, and we are targeting the populations, the substance use disorder, the serious mental illness populations, children, juvenile justice, as well as other justice-involved populations, lots of folks who use and need behavioral health services. So we've got a student loan repayment where we're specifically targeting child psychiatry, right? Because that is probably the hardest individuals to get, especially in the Medicaid program. We've got career pathways dollars where we're focusing on a new careers pipeline, getting people into a career, as well as a career advancement pipeline. Nursing, frontline staff like community health workers and care managers, as well as a host of professional and technical staff that specifically includes licensed master social workers, licensed mental health counselors, CASACs. We're hoping to add peers. That's coming. It's definitely something that's on our radar. But all of these focused because we recognize that there is this severe need in the behavioral health field. And I don't want to get too deep into it because it's a little off topic, but the populations eligible for those enhanced services in that waiver include, as I said, folks with SMI, all folks with SUD, children, justice-involved individuals, to provide those social care services, because we know it's very difficult for people to seek help behavioral health treatment and to stay in treatment if they don't have a place to live, if they don't have food to eat, if they don't have transportation. So we're working from that angle. But we also know that there's a lot of complexity in the public insurance system. It's really, really complicated. Eligibility can be restrictive. I think in New York State we have done amazing things to expand eligibility. Even before we got into, Obamacare and Affordable Care Act, we have really robust eligibility. So it's up to 223% of the federal poverty level for certain populations. That's pregnant population, but really, really high. We've included continuous eligibility for children, 0 to 6. We recently got that approved. Very excited about that. We're also using state dollars to provide benefits to undocumented individuals 65 and over. We recently expanded coverage to individuals who are in institutions for mental disease and have substance use disorder, so that we can use Medicaid to pay for services while those folks are in these institutions. And we're continuing to look at expanding to provide services to incarcerated individuals up to 90 days 90 days pre-release, excuse me. We'll see how we're going to do with that. We have to submit a waiver or revise our current waiver in order to do that under the new administration. I think we're all hearing both sides. But we'll see. As you heard Joe and Tricia speak about, coverage is also often very complicated when it comes to things like prior authorization, continuing reviews, what level of care is appropriate, and all of the things that New York State has done in those arenas, which I'm not going to repeat, but what I'll say is that we've worked really hard with those agencies, and I did some of this when I was at OASIS, and now I do some of it while I'm at the Department of Health. But really, a close collaboration. You can write the law, but in order to see it actually happen, you have to make sure that, first of all, that it gets into the contracting documents, that the guidance gets out there, that the plans are appropriately notified, that you're having meetings with plans, that consumers know what's happening. So it's really a lot of coordination. And then I would say it's a lot of monitoring. And that is probably where I think we need to most improve our efforts in all sorts of things. I'm gonna add network adequacy to that as well, right? Because we can set up systems, and we have systems to try and monitor network adequacy. We call it the PNDS, Provider Network Delivery System. Nice computer system, everybody puts their information in. But the data in there is only as good as the information that the people entering the data have, right? So if they're entering information and they don't know that a provider has died, they don't know that a provider has terminated their contract, or that the plan has kicked them out of their network, or that they're not able to take any more patients, then it doesn't get changed, right? And so we really need to think more comprehensively about how we improve those systems for the users, for the plans, for the providers, for everybody involved. Now, I think that a lot of that, I'm hoping that a lot of that is going to happen as we're moving forward with implementation of the 2 access rules that are current law. We'll see if they stay law, but they're current law, right? We've got the fee-for-service access rule, and we've also got the managed care access and quality rule. We have a group of folks that are working to implement all of the requirements in those rules, which include lots of things about transparency with regard to networks, transparency with regard to rates, specifically calling out rates in primary care, behavioral health, and OBGYN care, right? We'll have to be posting rates, rate-setting methodologies, ensuring that rates are 80% of the Medicare rate at a minimum. I'm going to stop there because that sounds like a great benchmark, 80% of the Medicare rate. If there is a Medicare rate, right, let's start with that. So for many behavioral health services, there is not a Medicare rate, right? Medicare doesn't pay behavioral health outpatient clinic or rehab programs the way that we pay them in the state of New York, the way that Medicaid pays an institutional rate. So how do you benchmark to that, right? You kind of have to figure it out. Medicare doesn't pay for residential care. What is an adequate rate for residential care, right? So these are all things that we have to think about. Also, we have to implement what they're calling a MAC and a BAC, a Medicaid Advisory Committee, and a Beneficiary Advisory Committee. The way that the statute's written, it's a pretty robust group of folks. I hope that we can use those groups, and that we can use even people in this room and the other agencies to fill those groups with folks who are really interested and concerned about behavioral health, and certainly include that behavioral health lens, because I think it's really important on that. And then I'm going to end with, I just want to mention the restricted recipient program, because Karla mentioned the restricted recipient program, and that is something I think that we are very aware at the department. It's run by the OMIG, Office of Medicaid Inspector General. We do have conversations with them. We all have conversations with them about this program. I think we certainly understand the idea and the need behind the program. I think it could use some updating in terms of trying to figure out who is appropriate for restrictions. It really hasn't been updated since all of the new laws have gone into place around behavioral health, and so whether or not it's actually restricting the right individuals, I think is questionable at this point.
Yeah. Well, thank you, Tricia, and really appreciate all the work on workforce issues, which are so critical, including turnover, which is really a big equity issue.
Yeah.
When you have people turning over and who can provide culturally congruent care. So Michael, let's turn to you. We actually first met a few years ago when I was looking at the Kennedy Forum on mental health parity. And at that time, the New York Attorney General's office had brought enforcement actions against 7 health plans for parity violations. And the activities have discontinued since then under Attorney General James, working with both the federal government and work on ghost networks. So can you talk about the Attorney General's efforts to increase access to mental health and addiction care?
Absolutely. So let me just make sure I have my time set here. Okay. Good morning, everyone. It's great to be with all of you. Brief caveat, the comments I will make today do not necessarily reflect the views of the Attorney General or the Office of the Attorney General. They might, but they might not. So just a quick overview of what I will say in the next 7 minutes. I'll give you just a quick view of what we do generally in the Healthcare Bureau at the AG's office, of which I'm a part. Next, I'll talk about 2 specific issues that have come up already multiple times this morning. Network adequacy and the audits that Karla mentioned. And then I'll just make a call to action, because I think this is an audience of provider organizations, and providers, as you'll hear in my comments, are really an essential part of ensuring access to coverage from an advocacy perspective, advocating for your patients. And that's not something you necessarily learn in grad school. I certainly didn't learn it when I got my master's in psychology. There were no courses about advocacy for health insurance coverage. That was a long time ago. But anyway, so the Healthcare Bureau in the AG's office protects the rights of consumers in the healthcare system. We do that through advocacy, public advocacy, speaking out about legislation, about various policies. The AG held mental health access hearings both in 2022 in New York City and then in 2023 in Buffalo. And we really heard a lot about the entire spectrum, from crisis, emergency care, inpatient care, lack of inpatient beds, outpatient treatment, things like network adequacy, insurance coverage issues. So it really reinforced a lot of what we already knew, with additional personal stories and testimony that people provided. And we also bring enforcement actions through investigations, through our powers under state law, which are pretty wide-ranging. So the first issue of network adequacy. Now, thank you, David, for your mentioning all of those settlements. And I think, I'm always, engaging in, I think like everyone else on this panel, always thinking about what could we have done better, right? I think we all have to kind of get in that mindset. What in the past could we have done better? Not from a regret perspective, but just to learn how to change in the future. And pretty much none of those settlements addressed network adequacy. They didn't, right? That wasn't an issue that just was resolvable or that we didn't focus on at the time. We knew it was an issue, certainly, and I've been saying in these sorts of meetings for 10 plus years, I'm sure my fellow panelists have been saying it maybe longer than that, that this is like parity 2.0 or parity 3.0, and we have the rubric of parity. Now, it's challenging, right? So that's one serious issue. Now, almost exactly a year ago, we published a secret shopper survey that I supervised and I wrote the report for. We made 400 phone calls to providers listed as in-network and accepting new patients for the most part, with 13 health plans operating in the state of New York. And we calculated roughly that those 13 health plans serve about 2/3 of the humans in New York with health insurance, adults and children. And what we found was pretty appalling. Let me just say, what we were going for was using a accepted methodology. We were posing as fictional patients, trying to get an appointment for either an adult or a child. And we came up with a 14% success rate. 14%, so 86% goes. And the methodology is set forth in the report. We left voicemails, we counted appointments, or we counted telehealth, offers of telehealth as successful appointments. We counted calls that in which screenings were offered. If the screening would be reasonably likely to lead to an appointment. So we were not just picking up the phone, making a quick call, and then hanging up. It was, we were really trying to follow a robust methodology to give these providers a chance to call us back and set up an appointment, and that we got those terrible results. And we also, in the report, made very specific recommendations about reform, including regulatory reform, and it's been mentioned today. And I will say it is very encouraging that the regulations regarding network adequacy, but also directory accuracy. And I really want to underscore that those two issues are intertwined. There is a very clear nexus between them. I think there are some folks, my friends, maybe in the insurance industry, don't necessarily see it that way. Maybe they will soon. But certainly in those regulations, which are the DFS and DOH regulations that are more or less the same, but with differences based on the MCOs or commercial insurers, they embody things like appointment wait times as the standard for network adequacy, because we have seen that the existing standards of providers per provider member enrollee ratio and time and distance really haven't moved the needle, right? So it's really about access in real time, and that's what the Secret Shopper survey was about. I just want to quickly highlight one example in that report, which again, it's comes from our consumer helpline. I may not have mentioned the consumer helpline. That's an important aspect of what the Healthcare Bureau does, that we do assist consumers in real time, much like CHAMP, for all kinds of health insurance related issues related to behavioral health, medical services, et cetera. So in the report, we discuss a mother of an adolescent young man who had severe behavioral health issues. The mother was unable to find an in-network provider after calling, I think, 7 names that were given to her by her health plan. She needed a child psychiatrist, so someone who could do therapy but also prescribe meds for her son. And her son is Black, so she preferred and really needed a Black psychiatrist for her son. And it was impossible for her to do that in network, so she went out of network. And ultimately what happened in that case was the plan negotiated a single case agreement, but after all the work of making all these calls and all this effort, which she documented, and I think that's the other point I want to underscore here, the taking notes, documenting the steps is vital, right? So that you have a factual basis for saying, well, we tried to get someone in network, but we couldn't after all this effort. And that's essentially what we did in the Secret Shopper. So the point there is that, you know, the network adequacy regulations, which I hope will become final soon, are a very important step in the right direction. I think there are some issues that maybe will be worked out in the future, in particular the interface of the federal No Surprises Act with the New York regs. I think folks who have looked at the No Surprises Act directory accuracy provisions will see that they are stricter than in the regs. And that's because, and there's also a non-preemption provision in the federal law. So that's just an issue that I think needs to be worked out, because we could have in New York a dual system where people on self-funded ERISA plans have better protections than people with commercial plans or Medicaid plans. And, you know, I say this to sound controversial, people in, you know, Alabama may have better, more restrictive, more consumer protective regulations for directory accuracy than the state of New York, because they don't make, I'm making this up, but I don't know if they have any sort of state directory accuracy provisions, but I just raised that as an example. Real quick, the other issue I wanted to talk about was audits that Karla mentioned. This is something that has been on our radar for a while due to consumer complaints. And it really, you know, one way to look at it is old wine into new bottles. That, you know, we, for years, and some of the settlements that David mentioned, addressed these soft limits for outpatient psychotherapy, such as 20 visits in, well, at first it was 20 visits in a year. That was it. After that, you were cut off. And you know, there were historical reasons for that. When Timothy's Law was enacted, that was the minimum, which became, for some plans, the maximum. Then the hard limit became a soft limit, which, you know, again, was triggered by volume, by quantity of visits within a time period for outpatient treatment, which I think we'd all agree is something we want to encourage, so that people don't go into crisis, so they don't need to go to the ED, they don't need inpatient beds. So we saw the soft limits, and then, you know, that was addressed in a number of our settlements, and we've seen, I think, less of that across the board. But now these audits have come in, and they are more onerous than the soft limits. I mean, the soft limit might have triggered a conversation, maybe a treatment plan, but these audits seem to require, and it's multiple plans that are doing them apparently, medical record from each session with lots of detail and so on. So it's, you know, and I'll just say it is, I think everyone in this room, certainly everyone on the podium, has a commitment to combating fraud and abuse in healthcare. So we all agree on that. This is not about being against anti-fraud measures, but they have to be reasonable. And I think the sort of a proof, well, more proof of that is that in the recently finalized federal parity regs, they didn't make a full exception for fraud and abuse programs. There is a partial, cabined exception to some of the NQTL rule. I think in particular the outcome rule, outcome aspect of the NQTL rule. But it's, I think the federal agencies, to their credit, understood that this is a nuanced issue, and that they did not want fraud and abuse programs to be kind of a sort of a blanket excuse for doing things that are not going to be scrutinized under the parity laws. So the final thing I would say, I know I probably went way over the time I thought I would have, but it's just a call to action to say that providers really are crucial in this effort to ensure network adequacy, make sure that people have access in terms of advocating for your patients. And I'll say that the example I mentioned about the child psychiatrist getting a single case agreement, again, as an out-of-network provider who wrote letters to the plan, was incredibly knowledgeable about healthcare law, and in fact some of the settlements that my office has entered into with some health plans. Again, doing this without any reimbursement, not in network, and presumably out of network, not in network because the person didn't want to deal with reimbursement rates and admin burdens that might be in play if he were in network, but really went to bat. And same is true for some of the folks I've talked with about providers dealing with audits. I mean, assembling these like session by session notes and sending them in, sometimes one place, two places, three places. And the final thing I would say, just what really inspired me in the last few months on this topic is I spoke at a American Psychiatric Association conference in DC on advocacy a few months ago, and there were a lot of younger psychiatrists there, like people finishing their residencies or just out of residency, and they are tuned in. They are tuned in on this issue. Now, this is, I think, a generational thing. I mean, we all know that the median age of psychiatrists in this country and the state is, older. Those folks typically are not in health insurance networks for reasons we all know and understand. But maybe the next generation is going to be primed to not just be advocates, but hopefully join the health plan networks.
Great. Well, thank you, Michael, and appreciate all the efforts, particularly on the audits, because we've been hearing a lot about how audits are driving providers out of network, and the ProPublica reporting that's been done over the last few weeks, I think, really shows that, as well as some of the Milliman and then RTI report data on out-of-network utilization, which is much, much higher for behavioral health than for physical health. So I wanted to open up a question for any of you to respond, but it relates to actually crisis services coverage for mental health and substance use disorder crisis response. My understanding is that New York has recently enacted legislation that I think takes effect in a few weeks, correct me if I'm wrong, mandating commercial coverage for mental health crisis response. So just curious how you see, particularly maybe that Joe, most appropriately for you, commercial reimbursement of crisis services playing into how we expand these services over time.
Yeah, I think that's going to be, that's one of the many things that we're focused on now in the commercial space. I think the way that the state, we really started collaborating, and I know DFS is not here today, so I'll do my best to represent their portion of it. But I think there's lots of things that we're recognizing. I think you could see from the data that Karla put up from the CHAMP slide, all of the vast majority of the issues that are taking place in commercial are mental health access issues. So that's been a huge problem, and we have been partnering with DFS for several years now, and we share a parity compliance contractor so that we're consistent between what OMH and OASIS are doing and what DFS is doing as well, and obviously DOH. But when there are certain services that there should be no prior authorization. You should be able to show up and you should get access to them because by nature they're critical, right? They're a crisis and they need to be addressed right away. So I think that's one of the things that we recognized is that expanding requirements in commercial for them to cover certain services that are essential is going to be a cornerstone of what we want to do moving forward. So absolutely, I think that's the direction where we want to go in, is that we want to help the spectrum of individuals experiencing mental health issues, not only people that have time to wade through all of these barriers that we're talking about, but those that have already reached the point where they need services right now. So I think that's the impetus behind covering crisis services and mandating that in commercial.
Great. Well, we have about 10 minutes left. Any questions from the audience? If not, I'll continue to ask, but any questions that anyone in the audience has? Yeah, go ahead.
Hi everyone, Vic Offiero at Haney's. It's nice to see all of you. And to Joe's point, DFS isn't here, and this is a issue I've raised with them before, but since it's come up quite a bit, the issue of the prepayment audits. We've seen it a lot, quite frankly, for our hospital members on the med-surg side for certain things. And I've raised the idea that it may be a violation of New York State's prompt pay law, 3224A, where the plans are supposed to pay the undisputed portion of a claim, and then come back to providers with the reasons why they're not paying the remainder of the claim. And it seems as though these prepayment audits are fundamentally violating that concept. Curious if the other agencies, if you have thought about this or considered those prepayment audits from that lens.
So I think what I would say is prompt pay is something that we've always worried about. Obviously, our providers rely on reimbursement to be sustainable. I think that generally speaking, the argument that would be made would be that the obligation to pay is not reasonably clear. So this is kind of what I was getting at earlier when I was talking about clarity. We've done a lot of work. I personally have done a lot of work in the insurance law and trying to navigate the terminology that's being used to make sure that you are not violating the rule of unintended consequences, as well as just practically speaking, how is that going to roll out on the ground? And I think truly, it's always in the details. And there's a lot of times, I think, where we as state agency staff will think, oh, we've got that covered. And then I think we've learned pretty quickly that perhaps our perception of the obligation, the requirements is different than the other side, right? So, I think that a lot of what happens in coverage and access has to do with a difference of opinion in what the rules actually are.
Other questions from the audience?
Yeah, I would just chime in quickly to add that, I've had discussions about this with some very smart people. There is, the words good faith are in the prompt pay law, and it is, so the idea that, there's some kind of fraud alert or some kind of algorithm, and really it's more the latter. It's like, and it's a number. I mean, it's not anything fancy. It's a threshold, just like the, 20 visits in 6 months. Something gets triggered, and that generates this massive request that is basically a black hole. And through a lot of effort, I learned that the pass rate, or the expected pass rate, is 80% for the charts. And you may have learned that yourself if you ask the right person. But it's to say that the statute certainly says reasonably clear, but if it's not even at the basis, if the lack of clarity is caused by something that doesn't relate to the actual rendering of the services, but it's an algorithm or a formula that has been triggered, that creates some tension.
Other questions from the audience? Yes, go ahead.
Thank you. Hi, Christine Kiken from the Legal Action Center. It's nice to be with you all in person. Kind of building off of that, I think that all the workforce efforts are obviously so needed. Workforce is such a huge issue, but at the same time, a lot of what we're talking about is like the example where there is a provider, obviously, and they're out of network, and a lot of what CHAMP does is single case agreements. And I wonder if there is like an effort to figure out, like map out, are there providers, and there are just so many that are not in network? Because I know the new network adequacy regulations that will hopefully be finalized, in the next few months, speak to, these wait times and getting, kind of incentivizing people into networks. But when we're talking about prompt pay and the complexities around all these fraud programs, it seems like a lot of providers are not in network, not just because of rates, although that's obviously a big issue, but because it's just expensive also to deal with all these plans, and then different plans have different rules, and so they're kind of navigating, there's a gazillion plans and they all have different claims processes. So there's so many administrative reasons also that I think are just a huge barrier, because we know that there are providers and maybe they're not mapped out exactly, but often you'll see, we can go out of network. And I think there's also a second piece of that, I think, is there's like a culture of going out of network for mental health. Like we just don't even expect to go in network because it's just been so long that it's not available. And I just think, I recognize it's so complex, and DFS isn't here to kind of talk about how that would work on the commercial side, but I'm just curious about how we're kind of like analyzing the workforce issue. How do we know where the workforce problems are and what kind of providers, and where in the state it's a workforce issue versus just an out-of-network issue?
I mean, I can speak a little bit from the DOH perspective. I'd certainly defer to my colleagues at the agencies. But, I think that what we hear is absolutely in the community-based space, right? That it's difficult for them for a whole host of reasons. you can, you can hang out your shingle now, right? So we at the Department of Health are happy to say we're expanding access and we're allowing, certain practitioners now to hang out the shingle and have mechanisms to bill in the Medicaid space. But what that does is inadvertently, right, make it more attractive for those same individuals that would otherwise work in a community-based mental health provider to sit at home in their office and do telehealth with their patients, right? Or hospitals that can pay far more. Or even, we hear also that folks go to the state, right, to work in a state facility because there's benefits and other things. So I certainly think in the community-based space, we have to figure out a way, and I will include the health centers there, right, the FQHCs as well, to shore up the workforce in those settings and with those providers. And I'll defer to you guys.
Yeah, I would say that, lots to unpack in your statement, appreciate it. I think one of the things you said is that there's so many insurers and it's so hard for providers to keep track of all of them and all their different rules and regulations that they have in order to reimburse a provider. Insurers are supposed to be submitting their network adequacy information to the state or DFS or DOH, and that's supposed to be accurate. And I think we're finding some trouble in that crux of it, where we have to hold them accountable for submitting that information. And it's going to be even more important with the new network adequacy regulations, because now we're moving to wait time standards, which is really the measure. And so we're going to have a hold on what's available and what's not, who's in network and who's out. So I think we're really looking forward to those being finalized, and so we can move forward. And I think one of the things that, speaking solely on the Medicaid side, the past several years, the governor has advanced a proposal for procurement of the Medicaid plans, right? Which is making them compete for the business instead of them being 14 and they can just apply. I think there's only 2 or 3 other states that have an application process. And I think there was a report that came out last year, early in the year, about procurement and the benefits of doing that and how the state could better manage our model contract and the Medicaid insurers. And typically, I think, when one side, if it's commercial or if it's state programs, when one side is leading the way and doing better, the other tries to catch up. So we try to pull each other up. And I think that's what we're going to be looking to see in the next couple of years, is how we can improve the space and the market in insurance for behavioral health.
Great. Well, I think we only have a couple minutes left, and this has been a great discussion. So before we close, though, I'd like to ask each of our panelists, just in perhaps 30 seconds, what members of the audience can do to support your efforts.
Let me go first.
Yeah, Joe.
Okay.
Go first.
So I think absolutely. So there's being vocal about the issues that they're seeing. I know I sound like a broken record when I'm talking to our provider system, but it's so critically important for them to register the issues that they're seeing in their complaints to CHAMP, to OMH, to DFS, to OASIS, wherever they can. You talked about the innumerable number of mailboxes we have. We really try to funnel it all to one place and understand what's going on, but all of the enforcement actions and things that I talked about are a result of those people raising their hand and saying, and I know it's so hard when you're trying to get access to something to stop and to submit a complaint and do all of that. But it's super important in order to make systems change. So I think that's one of the things that I would request. And then the other thing is just, continue the advocacy, because the space, there's clearly issues that we're seeing as a society that we need to address aggressively. So that's what I would say. They shouldn't let me go first.
Yeah, Trisha Allen.
So I would absolutely repeat what Joe said. If we don't know about it, we can't fix it. So having feedback loops with your agency, with the other agencies, filing complaints, if things seem weird or off as a provider when you're contracting with a plan or you're billing something for a plan, reach out to us. We have the mailboxes, we have regional office, we have program staff, and we're all very focused on the issue. So I know it's a repeat, but I do think it's just so important. If we don't know, we can't fix it. So use the processes that you have available to hold the policy and the plan accountable.
Tricia?
So I would say we do have a DOH complaint line also. So certainly, you know, it's important that that the information be documented as well, right? You have to document it. You have to go through those processes. You have to keep records of everything you're doing. But I would also say, as I said earlier, we do by July, hopefully we'll get it done by then, have to staff this Medicaid Advisory Committee and Beneficiary Advisory Committee, right? I would love to have people. It's hard to get people to be on these committees, right? But I think it's important, really important, that we have members with behavioral health experience. So you can certainly reach out to me, and I can put you in touch. This is happening through my division. I can put you in touch with the right people to get folks on these committees, because I think having a voice, you just can't say it enough, right? Repeat, repeat, repeat. I think having a voice, and there will be public, these will be public meetings, and there will be papers written, and you know, the more that it's out there, the more, hopefully, the more attention it will get.
Michael? Yeah, in addition to advocating on behalf of particular clients or patients, I would say using data as a form to inform the advocacy to the extent feasible and appropriate, you know, aggregating data of cases, of denials, of issues that come up, so that you can make out the case that this is not just one person, this is not just a random outlier issue, but there's a pattern here. I think that's what's really helpful, certainly to my agency, and I'm sure to other agencies as well. And I'll just sort of tie that to what to me is maybe the most important element of the parity rules, the federal parity rules that just were finalized. Focus on outcomes, or consideration specifically of outcomes, right? I mean, I would argue it's embedded in the statute. It certainly was in the reg 15 years ago, but it's now made explicit. So what does that mean for a provider? Well, you know, if you can, or a provider organization, whether it's a professional organization or otherwise, to assemble data of various types that you can hand off and make the case that you see a particular pattern. Now, you may not be able to make out a parity violation, right? And I was struck by the fact that, Karla's slides, it's like 3% parity complaints. And there's a reason for that, because it's really hard for one person to make that out. You need to do a comparative analysis, but at least the data will help inform that analysis.
Well, thank you to all of our panelists, and to Rockefeller Institute and InUnity Alliance for really a great discussion. Working across the country, I can tell you that how important your work is, and how New York is really a leader in this space. And we look forward to working with you in 2025 to continue to address these issues. So I'll pass it back over to Sarah, and thank you to our panelists.
Thank you, David. We were so glad that David could join us from Inseparable. He has such an incredible wealth of knowledge, and we probably, in retrospect, could benefit from having him have his own presentation, and hopefully we can do that with him in the future. Thank you to our panelists. I know everyone's very busy. We very much appreciate you taking the time to talk about these issues that are incredibly complex and difficult to talk about, sometimes in forums like this too. We hear your, what you said about advocacy and the need for us to work together and collect data and work with our community-based organizations in particular to make sure that we raise the profile of what's happening. We'll do our best to make sure that we can work with your offices to communicate opportunities for them to report and elevate what's happening and what their experiences are. And then also to take a look at maybe collecting data and helping in that regard to the extent that makes sense from our end. I did want to quickly mention, when I was talking to Karla, she had a slide. I know you had limited time, but she pointed out some disparities in use of the access line through CHAMP, and that I thought it was important here. I think that you had, I don't know what the statistic was, but people who were non-white were much less likely to be using the access line. And so I think we probably have some work in that area, and please correct me if I'm wrong. I think that was one of the stats there. We can make sure that we follow up on that. So regardless, we'll make sure that we follow up, make sure we're promoting CHAMP, collecting data, making sure that we're encouraging our providers to leverage opportunities to report what's happening. And thank you again for joining us. We will now take a break. everyone can have the opportunity to go grab some lunch, come back, and then the commissioners will be joining us shortly.
Good afternoon, everyone. We're going to get restarted. So we started with a really great set of presentations this morning. So for those who were able to tune in earlier, this is all being live streamed and will be available on the Rockefeller Institute website. So really good presentation by Champ, and then a really interesting panel discussion with representation from several of the agencies, really getting, I would say, into the weeds about some of the challenges that we outlined in the paper from Rockefeller Institute. So we are very pleased to be joined this afternoon by two of the commissioners who have been focused on these issues that we've been discussing today. I'm going to introduce both of them, and then I believe we will have Commissioner Cunningham will go first. So let me just give the backgrounds of each. So Commissioner Chinazo Cunningham was appointed by Governor Kathy Hochul on December 1st, 2021, and confirmed by the New York State Senate on January 24th, 2022, as the Commissioner of the New York State Office of Addiction Services and Supports, otherwise known as OASIS. She's a physician, researcher, and public health professional who brings over 20 years of expertise in substance use treatment to OASIS. Prior to joining OASIS, she served as the Executive Deputy Commissioner of Mental Hygiene at the New York City Department of Health and Mental Hygiene. She was a practicing physician at Montefiore Health System and a professor of medicine, family and social medicine, and psychiatry and behavioral health services at the Albert Einstein College of Medicine. She has more than 20 years of experience in research, care, and program development that focuses on people who use drugs. She also has partnered with the community-based organizations to develop pioneering programs to promote health for this population. She also led one of the first clinics in New York City to integrate buprenorphine into primary care. She has trained hundreds of doctors to treat substance use disorders in primary care, and she has led several research studies and published numerous research articles that focus on these topics. Dr. Ann Sullivan, Commissioner Sullivan, has served as Commissioner for the New York State Office of Mental Health since 2014. That's when I first met her, so I always like to enjoy the time that I had working with Commissioner Sullivan. She has guided the expansion of community-based treatment, reinvesting over $100 billion in community services and enabling individuals living with serious mental illness to live successfully in their community. Major initiatives have included the integration of physical, mental health, and substance use in care and treatment, integrating prevention, wellness, and social determinants of health in service delivery, reducing disparities in care and enhancements in the criminal justice system that divert individuals living with mental illness from jail or prisons. She previously served as the Senior Vice President for the Queens Health Network of New York City Health and Hospitals and Director of Psychiatry at Elmhurst and Queens Hospitals, where she developed comprehensive inpatient and ambulatory psychiatric services. She grew up in Queens, New York. She graduated from NYU Washington Square College and the New York University School of Medicine. She has published several different articles. She's a distinguished fellow of the American Psychiatric Association and has served as a speaker of the American Psychiatric Association's Assembly and its Board of Trustees. So we'll have both of them speak today, but please join me in welcoming Commissioner Chinazo Cunningham first, and then Commissioner Sullivan. Welcome.
Great. Thank you for the introduction, and I'm happy to be here today in person and for those who are watching online. Wait. Okay. So I'm just going to, unfortunately I missed the earlier sessions, but I'm going to, sounds like, go from some of the weeds to big picture here about what's happening in New York State in terms of addiction. And so this is a graph first to start out with overdose deaths in New York from 2015 through 2024. And different lines represent different substances. So overall, what you can see is there has been a dramatic increase in overdose deaths really for the past decade until just now. And so these are data that are still provisional and coming out of the CDC, so they're really within a few months in terms of their recency. And so you can see that there's a decrease in overdose deaths just in the last several months. So we're very hopeful about this. But again, these are still sort of preliminary numbers, and so we're waiting to see how they fall out. Also, what you'll notice here is that opioids, and particularly fentanyl, are driving the overdose epidemic. I think that's not a surprise to many people, but I think what does not get the kind of attention that it deserves is the role of stimulants. And so that's the yellow line for cocaine, and then also there's other psychostimulants as well, which are methamphetamine. But really, cocaine has a pretty significant role here in terms of overdose deaths. So one that we are focused on and I think has not gotten the attention it deserves. In terms of where overdose deaths are happening across New York State, so the darker the color here, the higher the rate of overdose death. And the highest rate is in the Bronx. This is not new. This is where I practiced medicine for over 20 years, so it's very familiar to me. And so this is a trend that we've seen for many years. But I think sometimes people are unaware of what's happening in the western part of New York and in the southern part near the Pennsylvania border. So you can see some of those areas, those counties also have pretty high overdose death rates as well. So it's certainly important for us to have a data-driven approach, know what the data are, make sure that there are resources available to those communities that are at the highest risk and experiencing the highest rates of overdose deaths. So switching to then who's in our treatment programs at OASAS, this is a graph showing those who were enrolled in OASAS certified treatment programs in 2023. And we sort of look at this by the crisis or detoxification programs, inpatient programs, the opioid treatment programs, which are primarily outpatient, and that's methadone, and then our outpatient programs and residential. And what you'll see here is that outpatient programs by far serve the largest number of people. That's not a surprise, right? This is the way that healthcare is moving. It has been moving for many years. And then followed by the opioid treatment programs. So we have, one of the most robust systems of opioid treatment programs in the country, over 100 opioid treatment programs providing methadone treatment. So, just a good sense of kind of what the services the type of services and programs look like in New York. When we look at who we're serving in terms of race and ethnicity, we see that about half of our patients are white, and then about a quarter are Hispanic, and then 20% are Black or non-Hispanic. So I know that this is, a focus on insurance, and so really thinking about who in our system has what kind of insurance coverage. This is data that are discharges by payment type, and so really the majority of people that we serve in the OASS program have Medicaid, so almost 3/4. Very small percentage have Medicare coverage, and then you can see 11% with private insurance and 7% with either no insurance or self-pay. And when you break this down a little bit more in detail by program type, you can see there are some substantial differences here in who we're serving and what programs by insurance type. And so what's striking sort of when you go down the columns with Medicaid, you can see 80% or so in the crisis programs and patient programs and the opioid treatment programs, but those numbers substantially drop when you look at residential programs. So just over a third of those who are in our residential programs have Medicaid coverage. Then when you look at no insurance or self-pay, it's column, you see a substantial amount of people in residential programs have either no insurance or self-pay, much higher than the other kinds of programs in terms of, that insurance coverage or lack thereof. When you look at private insurance, you can see that really there's overrepresentation of private insurance in the outpatient setting compared to the other program types. And then the other kind of coverage or payment we really see for residential. So that has to do with, congregate care and DSS payment. So that's not surprising. So not really, for the care, but more for the social services around there. So I think this is just really important information when we talk about, what's happening in payment coverage. We're going to see differential effects by program type. So kind of moving on to now the sort of intersection of substance use and mental health. This is an area that has gotten growing amount of attention, and Commissioner Sullivan and I are in the same room frequently and see each other frequently because of this. And so this is information for us really looking at how these two conditions intersect in New York State and in our system. And so the first bar graph is looking at the number of people with substance use disorder in New York. So it's 460,000, and this is from Medicaid data from 2023. And so the yellow portion of the bar are those with just substance use disorder, and then the purple portion of the bar are those with both substance use disorder and mental health disorder. So again, this is for people enrolled in Medicaid, and this is coming from Medicaid data. So you can see about 2/3 of people who have substance use disorder in New York State who have Medicaid have a co-occurring mental health disorder. Then when we move to the next bar in terms of those who have received substance use disorder treatment in our OASAS system, you can see that the proportions really are about the same. So of those who were receiving treatment in the OASAS certified programs who have Medicaid, about 2/3 of those have, again, a co-occurring substance use and mental health disorder, and about 1/3 have just a substance use disorder treatment. But also important to know is obviously those numbers decline, right, of who has these conditions and then who's getting treatment. And then the final bar is those who have received both substance use and mental health treatment in New York State. So again, that bar continues to decrease. And so this, these drop-offs are showing us clearly that we have work to do, right? That people need treatment that are not getting treatment, and that drop-off is worse for those with both substance use and mental health conditions. When you look at it a little bit differently, this is a pie graph showing those who have both substance use and mental health disorders in Medicaid. And then we're looking at what their treatment looks like in New York State. So of these about 300,000 people, half of them are getting substance use disorder and mental health treatment. 22% are getting substance use disorder treatment but no mental health treatment. 14% are getting mental health treatment but no substance use disorder treatment, and then 13% are getting neither. So again, these are the people, the denominator here are those with a mental health and a substance use condition in Medicaid. And then finally, when we look at what the mental health conditions are, we can see this is not a surprise that the majority of people have anxiety, 2/3, over 1/3 have major depressive disorder, and then a smaller percent have bipolar disorder or psychotic disorders. So what are we doing about this at OASAS? As I mentioned, we are working closely with OMH in many, many ways. Myself and the commissioner and all of our staff really meet all the time to talk about all the different ways in which we can improve the lives of New Yorkers who have both co-occurring disorders. So just some examples, and I'm sure that Commissioner Sullivan, we have a lot of overlap because we talk about the same things because of our partnership. I'll just keep it high level here. But we're working really hard with the CCBHC, so we're tripling the number of those. And I have to tell you, when you talk to other states, other states have a handful of CCBHCs, 4 or 5, and we're talking about 39 of them, and all across New York State, making sure that that people in every region have access to them. So that's very exciting, and such an important way forward. Then we have the crisis stabilization centers, right, which are now coming online, also very exciting for both the intensive ones and the supportive ones. Again, working together with OMH, both agencies providing funding, both agencies working really hard to make sure that they're established and implemented in a way that makes sense for people with either substance use or mental health conditions or both. Workforce is always a really big issue. We know that. We hear about it all the time. And we have so many things where we're trying to do to support the workforce. There's not one silver bullet. We know that. But the work that we're doing, so the scholarships, we're working on loan repayment, we have paid internships, cost of living adjustments, bonuses, all kinds of things. We are supporting that, and people from the OMH system are also eligible to get those kinds of scholarships and stuff like that. So really not just focusing on the OASS system, but also making these available to people working in the OMH system. In terms of our funding opportunities, one of the things that we heard loud and clearly from our Opioid Settlement Fund Advisory Board was really to make sure that we're using dollars, that can support both systems and people with co-occurring disorders. And so we fundamentally changed the way we do our procurement process, and all of our applications ask providers about what they're doing to address mental health conditions. Or if they're OMH organizations, what additional things they're doing to address substance use disorders. And so that's now part of the scoring process in our applications. So really showing that we need to make sure that programs are, really establishing themselves to be able to address both conditions and people with both conditions. School-based clinics, OMH has a huge footprint there and expanding, and we're working together to make sure that substance use screening is part of that. Housing as well, working together, again, with OMH and their expansion of housing to make sure that people with dual diagnosis can be served. We're doing a lot of work in outreach, so going out into communities and reaching those who are at highest risk, and we're working with some of the OMH-funded outreach programs to make sure that they have the training around substance use, and also working to now also add staffing for substance use, expertise and professionals along with mental health professionals for those outreach teams. Again, prevention, we're doing a lot of work in schools and really thinking, so on our side, our traditional prevention programs are doing some mental health screens and suicide screens, that kind of thing, and then on the OMH side, a lot of their prevention in schools, are doing the screening for substance use. So really trying to better integrate services there. And then we sit on multiple task forces. So, things like Daniel's Lost Task Force, right, where it's a behavioral health crisis. We're both involved. It's chaired by Commissioner Sullivan, but, certainly OASS has an important seat at the table. So all of these things are really being done with an eye towards making sure that we're addressing the needs of people with co-occurring disorders. And then just, some of the things that, we're doing in our system, so include universal screening for those who come into the OASS system, so screening for their mental health conditions, making sure that, they have psychosocial treatments for people with mental health conditions and, substance use disorders, including cognitive behavioral therapy and motivational interviewing, and then, of course, offering medications or continuing medications for those who have both co-occurring disorders. In our own addiction treatment centers, some of the work that we're doing include, so these are the state-run addiction treatment centers. We screen for suicide risk at every admission and for mental health disorders, and then patients who are admitted or have a psychiatric evaluation within 72 hours. And one of the things that we're doing is also sort of doing more specialized treatment for people with severe mental illness at currently one of our addiction treatment centers, and we're going to be expanding that to a second one. And so this is really changing the staffing pattern, thoughts about the, what the building infrastructure looks like, and really being able to take on people with more severe mental illness in these specific addiction treatment centers. So some of the stuff that we're doing in terms of addressing access to insurance and supporting this work, I know you all had discussions about CHAMP earlier today, so again, unfortunately I wasn't able to hear that, but I think this is an important part of our whole sort of continuum of services, right? And it's joint with OMH and OASAS, helping people resolve issues around accessing services and, available regardless of insurance status. And so, and you can see all of the different kinds of assistance that is provided through this program. And then this is just a map showing some of the coverage of the CHAMP program. So we have 4 providers that do statewide coverage, and then 9 providers that are doing more regional coverage in their regions. And so you can see the color codes here by the specific programs that are funded to do this work by region. So I know we don't have that much. I know I don't have that much time, and I know we do have time for Q&A. But just to wrap up, I can't give a talk without talking about some of our work, what we're doing going forward, and some of our guiding principles. I'm very proud of really the work that's happening at OASAS, and really we're focused on improving access to services for those who are at highest risk. And a lot of what we're focusing on is also improving access to medications. We know medications have been studied for decades, methadone, buprenorphine, and naltrexone, and really expanding access to those medications will save lives. It reduces the risk of overdose by 50%, 50%. And I can tell you as a physician in healthcare, there's not much we do that have results like that. I mean, blood pressure pills, cholesterol pills, the millions of Americans take have not even close to this kind of reduction in death as the medications for addiction do. So we're really focusing on making sure that people who need that access have that access, and that includes doing outreach and not waiting for people to come to us, but actually going out and meeting people where they are. And so some of that is street outreach teams, some of that is medication mobile units, bringing methadone to people. Some of that is the clinic-based outreach. A lot of that is public awareness and quick access to naloxone and drug test strips. And so really trying to get out there and make sure that life-saving services are available. And this is really through our guiding principles, which is using a data-driven approach, which is why I start with data really in every single talk, right? Because we have to know what the problem is in order to know how to address it. Using harm reduction, so again, meeting people where they are and really focusing on reducing harms, not necessarily expecting that people are going to all be abstinent. That's an unrealistic expectation, but we still need to keep people in our services and reduce their risk of dying. And then also using an equity lens in everything we do. We know that a lot of drug policies have been racist in this country, and we need to make sure that we're not making that same mistake as we move forward. Thank you again for inviting me to be here with you all, and look forward to question and answers after Commissioner Sullivan's talks. Thank you.
It's always a pleasure to present with Dr. Cunningham because, and I'm going to be talking a lot about insurance. Sorry. I can stand here. I guess I can. Is it easier if I stand here?
It doesn't matter. Whatever you want to do. You will be on camera if you stand.
Okay. Well, then I want to stand here so I can be on camera. Okay. First of all, it's always a pleasure. And one of the things we're talking about closing the coverage gap and access, and one of the critical things about access is if someone walks into a mental health clinic or if they walk into an addiction clinic, do you really want to sort of give them half of the service that they need if they happen to be duly diagnosed and send them down the block for something else? Or do you really integrate care? And that's what I think Dr. Cunningham was talking about. I won't be talking about it as much, but everything we're doing together and every new service, which I'm going to talk about at the end, that we're putting up is integrated. And I think that's a change in culture. And I think insurance is a culture issue too, which I'll talk about a little bit. Okay, first, just to talk a little bit about what I think, as a commissioner, you get to, just like many of you, go across the country and hear from other states. And it's important to recognize just how generous a Medicaid and insurance state New York is. I mean, 5% of New York is uninsured. That is not true of a lot of the United States. And so that first one on the left is just the population of New York. And you can see that private insurance is a chunk, but Medicaid's a big chunk. Medicaid's a big chunk. If you go to this thing on the other side, it's who's in our public mental health system. And herein becomes the rub of a lot of the financial problem, is that the heavy, heavy Medicaid population in the public mental health system, which you're not going to see you're not going to see a slide like that on a lot of the medical side, but you do see it on the behavioral health side. You see a huge population of Medicaid. So we are dependent largely on Medicaid payments, and then some involvement in, some people have VA insurance, some people have commercial insurance, but heavy, heavy Medicaid in the public mental health system. These are just the numbers, just to say. So we're really talking about almost 6 million people, close to 5.5 million people in New York State on Medicaid. And then you have Medicare, other insurers, et cetera. So that's just the big picture of the insurance. But what does it kind of mean in terms of access, if you think about it for a minute? And so I just picked two things that we have some data on. One is people leaving emergency rooms and getting follow-up mental health care. And the other one is people leaving hospitals for mental health issues and getting follow-up mental health care. And if you look at it, and you look at the national averages and the New York State, we're doing pretty good in New York State. And most of these indicators, we are above the national average, even whether it's commercial or Medicaid or commercial or HMO or our HARP population. We're either at the average or above it. But then when you step back and say, so what's the average? You're talking somewhere about 20 to 25% after someone has gone to an emergency room for a mental health issue or been hospitalized for a mental health issue, still not getting some kind of follow-up. So while I'm proud that we're probably leading and helping pull up that average, there's a gap. There's still a big gap. And that's something that I think is multifactorial. Insurance is clearly one thing, but there are lots of things. There are lots of things that contribute to the gap in access to care. And we're going to be talking about insurance today, but one of the big things is the availability and quality of needed services. And that's what I'm going to talk a little bit about, because I always have to talk about the governor's billion-dollar budget and what she did afterwards, because I'm so happy about it. But that and what Dr. Cunningham was talking about, which is the huge increase in services that's happening in New York. That's critical for access, because whether you pay for it or not, if you don't have the services, it ain't going to help. So those things are really, really important, and that is critical. But I'm not going to be talking about it too much until the end. But then you get into the other things, engagement in communities. Again, it's not just insurance, but it's engagement in community. You know, a number of years ago, and I don't think it's changed, I had a conference with the health services system in England. And it's public, it's a national health service, okay? So they pay, you can also get some private insurance in England now too, but national health service. So theoretically, everyone's covered, right? Disparities all over the place. So the disparities in care in different neighborhoods, different parts of England, different parts of London, and they are struggling with it despite the insurance coverage. So even insurance coverage, I'm going to get to all my complaints about insurance coverage in a minute, but it's not just insurance coverage, that's my point. And the engagement, working with diverse communities, having services that reach out and connect with those communities, the kind of thing that Dr. Cunningham's talking about, those are all critical. And if you don't have those, again, insurance coverage doesn't solve it all. And then you need your well-trained workforce, but then you need things paid for, and you need to have insurance coverage if you're going to do that. So what have we been doing? Now, you've heard about all of this, but I want to, earlier, and I know Joe, you did a great job at talking about some of the specifics, but I wanted to talk about these in generalities in a way because I've been around a long time, and I've seen some of the progress in some of this. So the 4 key areas I wanted to talk about were parity, adequate payment, big, big issue, adequate networks, big, big issue, and then timely access, big, big issue. I want to talk about the history of parity for a minute, because, you know, culture dies hard. We all know this. And the culture of the segregation out of mental health and substance abuse services goes back in the United States to the earliest days of medical care in the United States. So if you look at 1920s and 30s, when group health insurance first began to appear, these were little things that grew up in the beginning. Nobody covered mental health. Nobody. That was the states. Those were the asylums. Nobody covered it. you begin to move along a little bit. Post-World War II, it begins to eke in a little bit to insurance coverage out there, but still, you know, not big time. Then you have Medicare and Medicaid. You know, I graduated my residency in the late 70s. So Medicare and Medicaid were not forever. You know, we feel like now that they've always been there, but guys, they haven't always been there. But when they were established with the discrimination against mental health and substance use. Big time. Remember the Medicare deductible stuff? 20% deductible for a medical visit, 50%. You had to pay 20% copay for a medical visit, 40% copay for a mental health visit. That was designed in the first days of Medicare. No parity, no parity. Limitations on inpatient, gross in Medicare, gross in Medicaid when it started. And then they left the state hospitals responsible on the states. So they said, okay, states, the most seriously mentally, it's like saying, okay, cardiac patients are really expensive. So I think we should leave all the cardiac patients over here in the corner for the states to take care of, and we'll take care of everybody else. That's not what they did. They put all the mental health patients over in the corner and said, we'll take care of everybody else. So it's subtle, but it goes way back. And I think it's a little bit bigger than just the finances, although they were worried about the finances then because there are a lot of people in state hospitals. But a lot of the people in state hospitals are people currently today in nursing homes. If you really look at the data, those old state hospitals took over everybody. But here, what happens? You begin to keep mental health and substance use separate. You begin to see it as something not as valued. And once you've got that in your system, it's a big nut to crack. So what begins with parity? Pushing in parity. And I'm old enough to have been around and actually have gone to the feds to advocate for that first Parity Act in 1996. And the first Parity Act that they tried to put through was really quite extensive. Would have done some great stuff, but it couldn't get through. And they were actually saying to us, well, I don't know if it's true that all those mental health treatments really work. Do you really want to, I remember these conversations. Do you really want to insure people because you really think they get better when they're depressed, when you treat them? You really think they get better? Is this worth? 1996, the Parity Act that passed only covered lifetime limits and annual limits, and that was it. Everything else fell out. Then it went to the states, and the states started to pick up across the country some parity acts, and we had Timothy's Law here. But it was interesting, even Timothy's Law had restrictions on the number of inpatient days for psych treatment, et cetera. States start pushing it. Finally, in 2008, you get the big parity law. And now it's 2024, almost 25. And what did we talk about all morning? Making that parity law work. Making that parity law work that many years after the parity law was passed. And so the work has to continue, but I think it's important to see it because it's an insidious way that our medical system, and it's our medical system as well, I'm going to talk about, it's not just the insurers. Everyone has said that in the United States, we pay well for what? Acute care and technology. We don't pay very well for maternity care. We don't pay very well for rehab, and we pay horrifically for mental health and substance use. Okay, so when we go to bat for these things, it's just important to remember the history, because I think there's an implicit there's a bias in everything that's there, but it's there so long that you've got to fight it. Okay, so what do? You have to take different approaches, and I know you talked about this a lot today, but one of the big ones, which I just want to emphasize, was a couple of years ago when we got through legislation, the medical necessity. Did we talk about this? But what this really means, though, is, you know, there's medical necessity criteria. Milliman does a great job of medical necessity criteria. They have books and books and books of what enables you to, what level of care you should be at, and they're pretty good. And then there's there's various scales. They've been out there for a long time. But the insurers for mental health decided that they were going to come up with their own medical necessity criteria, and it was basically discriminatory medical necessity criteria on many, many levels. And so that piece of legislation meant that they had to come to us, the Office of Mental Health, and actually Oasis has had that earlier for some addiction services. They had to come to us and show us what they were using as the medical necessity criteria, when for years before they told us it was proprietary and nobody had the right to see it or know it. Now they had to come. And I had a team of people reviewing tons of medical necessity criteria, and we bounced them back, and then we came back, and then we bounced them back. But are we sure that they're following them? No. And we have to do the enforcement, and we try to keep in touch with the hospitals, and we need information from them. But it's critically important that we know whether the new medical necessity criteria is being followed. Why? Because that's the kind of where the rubber hits the road. When your family member feels, I don't know, they told me I can't stay in the hospital another day, or the family member says, I can't get somebody, that's where the medical necessity criteria comes in, and that's where denials come in. When I worked for the Health and Hospitals Corporation, we had some insurance companies, and this was on the medical side actually, that would almost routinely 50% denial rates for one-night overstays in the medical ED. You know, come on guys, 50% all the time? You begin to get suspicious. So my point is that there's medical necessity criteria. You have to be very careful about this. This is a critical point. It's one of those non-quantitative, discriminatory things that very easily slips in. Now, I'm not saying it's all bad people doing this for bad reasons. I mean, some people look at it and say, well, is it really, really necessary? But that's where you have to have people who are doing this work who really understand what is really, really necessary. And that's why you have to have good criteria, and you have to have good enforcement of watching out for the criteria. So all the quantitative and non-quantitative enforcements, and then various legislation which we put through to say that you can't, if you're admitted on an emergency basis to a hospital as a kid or an adult now, you can't get all this every other day call from the insurance company to find out if somebody still needs to be there. There's 2 weeks that you're, come on guys, let's understand that if you're in for an emergency admission, that 2 weeks stay minimum, then maybe you can start talking about where someone goes or what someone does. The other thing, which I think in some ways, and maybe we haven't asked them enough of this, of the insurers, they are responsible for helping with discharges. And that's the other thing which we are now putting in place in regulations in New York State. Discharge planning regulations from the ED and the inpatient. And that falls to the hospitals, but it falls also to the insurers. So we're working with the insurers as well. So when insurance tells you you don't need to be in the hospital, but you need blah, blah, and the doctor says, but you need this, this, and this, if you can't find this, this, and this, it's not solely the responsibility of the hospital or solely the responsibility of the practitioner or the family, it's the responsibility of the insurer to get it too. And that's where the discharge regulations, things we're requiring, I think will have an impact. Now, providing effective reimbursement. This is something which I'm sure Joe went through. So we're now doing things like mandating that our clinics, licensed mental health and substance use clinics, if you, a commercial insurer uses them, they have to pay at least at the Medicaid rate. And that's really important, but it's also a little weird. Why would you pay ever less than the Medicaid rate? If Medicaid, and believe me, the actuaries spend forever deciding what's cost. And then they put it in, and then they come up with a cost. And half the time we feel that even the cost they came up with isn't fair, you know, should be more, blah, blah, blah. Commercial pay is paying less than the cost of the service? Come on, guys, come on. So that's the kind of thing that has to be dealt with on an ongoing basis in terms of ensuring that there's adequate payment. And then on the adequate payment thing, I just want to say one other thing, which people talk about, but they don't talk about too much. Where do we get this concept that mental health, inpatient, let's take inpatient as an example. Why are they money losers? Okay, they're not paying enough for the cost, let's say. But if they pay enough for the cost and you get a little bit of a margin, and I'm running a big hospital, and I get a margin of 30% on 20% sometimes on some of these surgical services, and I get a margin of 5% on mental health, why would I grow my mental health when I could grow my orthopedics? Who decided that orthopedics should give a 20% margin? The healthcare system, guys. There have been people who've said, rebase those rates. Oh, Oh, God. You should hear the furor. And the furor is from the insurance companies, the providers, everybody. But it's what society values. It's ultimately what society values. So if you're going to pay a minimum for mental health and substance use just to get by, and you're going to pay a 20% margin on something else. Now, what they will tell you is, well, but then we use that 20% margin to help subsidize the losses here. But then when the going gets rough, what happens? The loser gets the beds closed, not surgery. When everybody's happy, it's okay, but not then. So we have designed exactly, what's that famous saying? You get exactly what you design. So we have designed a system that overall has decided to pay less for these services, and then we say we're paying less, therefore you're not financially viable, therefore we maybe can't continue to support what you're doing. So it's fascinating. And then the state moves in, and in New York, the state has been incredibly generous about moving in to cover uninsured, to cover deficits. We have deficit funding across almost all of our programs. We have all this stuff just to make sure that it works. So again, for think tank people, it's a philosophy here that I think is getting us really kind of stuck. And if we really want to think about it, it's going to be very hard to throw up all the apples and kind of have them come down differently. But you got to think about it. Why have we gotten into this predicament to some extent? And so these things help. It helps to say you have to pay this, you have to pay that, and to keep going back to the legislature to put in laws that require payment for crisis services, that require payment for this, that require payment that's adequate. Is just interesting, is what I'm saying, because they're not going back to say for some things, but not for cardiac, not for other things. They're not going in and saying, let's pass a law to make sure that you pay enough for cardiac transplant. It's not there. Okay. So, but these are all helpful. These are all important, and it shows the commitment, I think, of New York to working on all these things so that we make sure we get paid. Again, multiple increases across time and space. This is not minor. This governor has really increased the dollars by increasing rates, inpatient, outpatient, all across the board. And this has helped. This has seriously helped the system. It's not just the COLAs that everyone talks about. It's this kind of rate increases that increase the base funding of Medicaid, fee-for-service, and then usually that lifts the floor. Okay, then the other piece is really exciting, I think, for New York, is with the Department of Financial Services working on adequate networks, and I know you probably heard about this from the AG and from others, adequate networks, people being able to get an appointment. When we get this one going and then we monitor it, this is really powerful. This is 10 days, you should be able to get a mental health appointment. That one's really cool. That one's really good, and I think if we can really get that going and get that out there, that will move the system to say you've got to find providers, you've got to have adequate networks, you have to get people services, and you have to get it in a timely way. So this, but again, it had to be put into law. It had to be put or pushed in the regulations. This is regulation. It has to be pushed in the regulations to make sure it happens. But if this one happens, it can have a really significant impact, I believe, on getting people the services they need. Because I know you've all heard, just like I've heard. I get calls all the time. I called my thing, I look and I can't find somebody. Do you know someone who takes blah, blah, blah insurance? I mean, you shouldn't have to find someone who takes your insurance. You should be able to call somebody and get an appointment in 10 days if you need a mental health appointment, if they take your insurance, if you're paying for your insurance on the commercial side. Okay. Now, the other thing I just want to highlight here, and Chinazo had talked about this, these certified community behavioral health centers and why they're so important. One, they provide really good integrated care. They have all kinds of services. They have intensive kinds of services. They have outreach services. They really provide the whole panoply of services lifespan. But the other great thing about them is they are funded on a mixed thing, which we hope doesn't disappear, of cost-based Medicaid, much like the FQHCs. So this has been a real boon to mental health, because for the first time, we have a cost-based system of payment for certified community behavioral health centers, and the state has invested in expanding those from 13 to 39 across the state. This is huge. And the state has also put in a pool for uncompensated care, knowing certified community, they have to take everybody who comes in the door, and that's a great thing. But we also know that there are some people who are totally uninsurable in New York State. We know that, no matter for whatever reason, they really can never get insurance. So there's an uncompensated care pool, which the state has put in for this. So the certified community behavioral health centers are financed well. They give us the ability to do it on a cost basis, so they can pay a little more sometimes for staff than other systems. And they provide really comprehensive integrated services, and they have to provide them, and we monitor it. So this is a great expansion of services that also takes into account costs. Okay, so I'm going to go through these quickly, but again, just like Chinazo talked about some of the exciting things that are also happening in addiction services, these are some of the exciting things that are happening in mental health. And it's been these last two budgets. We got $1 billion the first year, over close to $500 million the next year. I'm not going to go into great detail, but just to give you the buckets of prevention, access to care, and specialized services. And I'm not going to go through all these, but if you just look at the number of them, it's kind of cool. You know, you're just looking at how many in each column. On the prevention side, is a critical point here too, that mental health, certainly there has been some more on the addiction side, but mental health has not done a lot on the prevention side. And it's not been paid for a lot on the prevention side by insurers, any insurers. So one of the things that we're trying to do is increase that. So where does prevention begin? Be pretty hard. One, for kids, school-based clinics. You put school-based clinics in, and I think you heard probably from Joe and others that school-based clinics have to be paid at the Medicaid rate by commercials, and then we up the rate for the Medicaid for kids for school-based. But the other place is pediatricians' offices. So we are also growing something called Healthy Steps, which puts a mental health clinician in a pediatrician's office of 1,500 or more kids, families. They get one for every 1,500 families. And that means that there's someone there to work with you before you have a mental health diagnosis, to work with families under stress, to work with kids under stress. When you talk about ACEs, remember the conditions that lead to not just mental health problems later in life, but also medical problems later in life. If you have someone in a pediatrician's office working with those families earlier, you can intervene and you can prevent. So that's critical. And ultimately, you would love to have insurers pay for that. And one of the things we're trying to think of is if we can get that into the Medicaid benefit, because if you do that, then maybe we can get it into other people's benefits so that you pay for this. This is early prevention, mental health. It's important, it's as important as mammograms and vaccines, even though I know there's some controversy about vaccines, but it's important that all the other prevention that we do is this. And probably a little bit even more important sometimes in terms of preventing the long-term medical health sequelae. Then there's community access, CCBHCs, a whole growth of services, especially intensive things like ACT and critical time intervention. Growing those numbers, growing that availability, because again, if you don't have, even if Medicaid pays, sometimes we have to fight to get commercial to pay, but even if you have it, if you don't have the services, it won't work. And then lastly, the services for the highest need individuals. And these are the ones that include things like street outreach teams. And there are like 2,500 individuals living in the subways in New York City with serious mental illness, living in the subways in New York City with serious mental illness. We have lots of outreach teams from the city, but we also have specialized state option support teams from the state. All this is paid for out of state money. Safe option support teams, outreach teams. I will guarantee you that 90% of those guys are Medicaid eligible, but they've lost their eligibility, they've kind of gotten lost to society, they're kind of lost, and so who picks up the tab for doing those services, for getting those people back in, for doing all this outreach? It's the state. So just kind of remember that. And then you've got to get them back on their benefits, get them connected, do everything. But these services are critical. We've been able to successfully house over 750 people, many of whom spent 5, 10 years on the streets or the subways. It takes a lot of work. It takes a lot of work, but it can be done. It can be done. And the state's paying for that. And in some ways, in the future, maybe if you were Medicaid eligible and you were once enrolled, most of these guys, a lot of it, 10, 15 years, they probably have fallen out. But some have been on the streets for 2 or 3 years. They were enrolled at one point in a plan. But all that gets lost. So it's just something to think about. The state, maybe that is the job of the state to do that work, I don't know. But the individuals who can connect back to plans, then you should get them quickly connected into services and get the insurance. Okay, this year's budget, a lot of work with individuals who have been incarcerated. This was last year's budget, not this year's. Last year's budget, incarcerated individuals. Again, more work with kids and the expanding the insurance coverage. A lot of that went in last year, so I won't go into these details. But again, a huge investment in mental health. And all these things that we're putting up are integrated care. Just remember that they're integrated substance use and mental health. So I'm going to go through this very quickly. The other thing about access is we have to change what we do too. And so one of the issues is what we've been talking about here with integrated care. And this started a few years ago where we are working with all our mental health clinics to put MAT treatment for opioids in our mental health clinics. And we have a collaborative. We work very hard with them. The numbers keep going up. And now of the 400 clinics or so that we've had in this, about half of them are now close to providing, I think maybe a third are providing MAT and the others are close. So it can be done. But it's a lot of work to change systems. So I understand how it's hard sometimes for insurance companies to change what they do, but we have to change what we do too. We have to integrate care here, make access more available, et cetera. So this is just some numbers that talk to that and making sure that these services are really being provided in the mental health side of the picture. Now, I just want to talk about Youth Act for 1 minute as an example. All those nice new services I put up, this is one of them, Youth Act. Youth Act is an intensive outreach teams that work with kids and families to prevent hospitalizations, to prevent ER visits, to get kids who are having trouble on the mainstream. First funded now by Medicaid. Now, we're going to have to go through a process to get this funded by commercial insurers. Why wouldn't you fund it on your own? Why wouldn't you? I've got it. I can show you outcome data that'll show you that the kids are improving. It's a team of people who work with the family that prevent the long-term issues that we know can cause so many health problems, so much else. Why wouldn't you just fund it? And in fairness, what we hear, well, you know, ACT, in order to make it work, it has to be paid on a little bit of a bundled rate. You can't just pay for every individual service. You drive them nuts and they won't have the time to do what they need to do. So we bill Medicaid on a kind of a bundled rate. That's hard. I agree, that's hard for an insurer to do. For a particular service, let's say, like ACT. And what they will say to us is, oh, great idea, we think it's good, but you know, I don't know how we can work that out in terms of, even if and then it lingers and it lags and it lingers and it lags. And then eventually, we'll probably be putting this in DFS regulations to say you have to do it. So what's the issue here? It's not a partnership, guys. It's not a partnership where people come together and say, here's a great service for kids. We know it's going to save you money. We know it's going to also ultimately help these kids get where they need to be, but getting a big insurer to pay attention to how they're going to bill for something like this. Similar thing with First Episode Psychosis, On Track, First Episode Psychosis, an absolutely great program that shows that if you do this as a team with individuals who had their first episode of schizophrenia, you work with them, they stay in their jobs, they go to school, you get rid of the whole disability phenomena. Great program, but again, it's got to be bundled. It can't be something that is traditional, changing the way they see it. It's interesting. So sometimes I actually think that those mechanics are also obstacles. And how do you get someone to say, okay, I'll work through the mechanics, it's important enough. When your premium is less than 5%, when you're paying all of behavioral health and Medicaid, and including substance use, mental health, 5%. Tops, 5% expenditure. So they kind of look at you and go, well, you know, but I got all these other things I'm spending my money on, and you want me to worry about this ACT team thing that you're doing in New York, and I'm a national company? So I'm not saying it's simple. That's my point. Sometimes it's complicated. But I think if we had a partnership and we worked together on it, we'd get a lot further. And I think sometimes when we can't get that way, then we finally go to things like legislation. Look, you've got to just pay for it, period, because it works. So I think those kinds of partnerships between those of us, and again, why is the partnership so needed? I think because of the long history of mental health and stuff being over here on the side. So it's just not given the kind of attention that you would get for a team like this if this team were doing this with a cardiac problem. They jump at it a little bit more, partly because maybe numbers, I don't know, but the reality is it's harder to move it. So just to mention that. Okay, so then in closing, just these are all the things I think that are important to think about doing. And I would just like to emphasize the prevention one, you know, because we're kind of chasing ourselves a little bit here. And the great thing about the 1115 waiver is social determinants that are going to be paid for. Some things like a little bit of money towards transitional housing, dollars towards, a lot of dollars for training, but dollars towards things like things you might need to buy for someone, like air conditioning, this kind of stuff, if you need it for asthma. You know, getting social agencies to work and pay them for what they do, Meals on Wheels, the kinds of things that go out and provide nutrition, provide what's needed. That 1115 waiver will help. It will help with Medicaid. But maybe there should be more of that in all the insurers too. There's gym memberships, but gym memberships hits more the middle class in my book, the upper middle class, because most of the people who are the lower middle class are too busy working 2 or 3 jobs to go to get their gym membership. But if you think about it for a minute, why not? Why not have more of these things built in, because they know, and they do it selectively. But again, there are things like this that could work and be helpful for mental health as well. So I think that that kind of prevention is critical. And I think that the more we can keep everybody's eye on that. I'm old enough to remember when mammograms weren't paid for by insurance companies, you know? And now people would say, oh my gosh, how could you not do that? I mean, look what you've done in terms of preventing breast cancer. Look what you've done in terms of, and so they have come forward and they have done it. So I think these things can change. That's my point. I think you can, but you have to keep pressuring a little bit, because the healthcare pot is limited. But I go back to my first thing. We were, from the beginning, designed to be on the fringe of that healthcare pot. And if you're ever going to really kind of rearrange things, it takes a lot. It takes legislation, it takes DFS, it takes our design of care, and it takes the expectations of the public and society, too, I think, as to what's important and what's worth paying for. Okay, thanks.
I know we're talking about Q&A, but I'm also aware of time constraints that you have. You have to be somewhere, the 2 commissioners. So I don't know if we have, do we have time? It's about 20 after.
I have a few minutes. Do you have a few minutes?
I think we could do a few minutes.
So we'll like 2 questions. We'll limit it to 2 questions. How's that? Okay.
Are you?
Commissioner Sullivan, you say here.
And maybe have mics so that anybody who's listening to the live stream, if you're going to ask a question, use a mic. Does anybody have a question? Because I do think it's going to be a second. Okay. So really great conversation, great talks by both of you. So now that we are much more aware of the history and the cultural issues, in particular about parity issues, what do you think we can do as a society to change that culture more? You gave the example of the mammograms and so on. What do we do when it comes to behavioral health? How do we change that? Obviously, you both have a leadership post from which you can talk about it, but the rest of the world.
Well, I think one of the things that can be very helpful is to help people truly understand the interface between mind and body here that we're talking about when you talk about health. And it's all connected. It's all connected. So there's tremendous data out there from the ACEs studies and from other studies that show that if you're not taking care of your mental health, your physical health goes down the tubes. So I think if people could really understand that, they might stop thinking that we're dealing with separate issues here, that they are really entwined. And it's what, you know, if you hurt your arm, you know, you go to the doctor. If you're feeling depressed, you live with it for a while, maybe too long, before you get help. So individuals still have trouble seeing that mental health issues and substance are just as important as everything else. And I think when you can get people to see that, I think that can change a little bit maybe how you look at what you pay for and what you invest in. But it's a big lift. It's a big lift, because I think we have not traditionally done that. But I think it would help. But I think insurers, healthcare providers, they can lead in that if they want to. They could be voices about it. And I think that it would be great if they were.
Yeah, I would just add to that. I mean, I think you know what I heard when Commissioner Sullivan was talking, and especially about the history, is a lot of stigma around mental health and substance use, and I do think it still is the #1 barrier, biggest barrier, and in terms of even fighting for access and fighting for reimbursement. But I do think the tide has been changing, which is positive. That certainly, I think, more for mental health, especially after the COVID pandemic, right? We've seen more and more people sort of come out and talk about their mental health issues, and maybe it's starting to happen, with addiction too, because so many people are affected by this personally. So I do think addressing the stigma is a big piece of it, but it's also, and data is important, but we also know that data are not good enough. It's not sufficient. It's necessary, but not sufficient. And we need noise. We need voices. We need people to demand better, and I think that as that happens more and more, there is a willingness to change the culture. And so, but that, it takes saying you have a mental illness, your kid has a mental illness, your kid has an addiction, you have an addiction, your family member has it, right? And saying this is not good enough. This has to be thought of similarly to the broken arm and the physical health. And so, we are seeing changes of it, but we still have a long way to go.
So I guess on the product side, what we're trying to do in terms of behavioral health is we've, partnered with various telemedicine providers to cut costs both on the front end and be more be transparent on the front end, trim costs on the back end. They market those programs heavily in terms of like $0 copay for behavioral health services, easier access to try to address that network adequacy. So is there anything else we could be looking at in addition to those kind of programs?
I think the telehealth has definitely opened a big door, and I congratulate you on using that in that way. I think it's great. I think it offers a wider span of availability of services, which I think is terrific. So I think that's great. I think the other is, I think it's also the ease of people. Maybe what you could do, I don't know, you probably do this, you probably do send out things to your constituent on mental health and what's available, and you kind of try to keep people knowing what's available. One area that I think would be important is for you perhaps to think about the prevention side a little bit too. And think about being as a leader in maybe paying for something like, could be another model, but something like a Healthy Steps. Because, if people get an experience of mental health services, like in their pediatrician office, that is positive early on, they're having a tough time, they just had a baby, they got the blues, they're not maybe clinically depressed, but the babysitter quit last week and they can't now, and they're under a lot of stress, and someone talks to them and helps them, and they get that kind of experience early on. It makes a big difference in terms of how they view life and the things you go for help for. So I think the more you can infuse that kind of thing into the services you're providing, whether it's a pediatrician's office or an OBGYN office or even, geriatric care office, it's not just screening for depression, it's offering kind of prevention and that kind of thing at the same way. I think that could be really very, very helpful in expanding people's comfort level too with mental health. So just like you go to your doctor for when you have a PCP, and then you go if you're really sick, but you don't always wait till you're really sick. So expanding that in terms of medical practice, because people trust medical practitioners. That's who they trust. So if you can get that through there, I think you could have an impact.
All right, so please join me in thanking both our commissioners, and we'll have some closing remarks from Sarah, but thank you again.
Thank you both for joining. You know, the remarks that were just made really echo, I think, the opening that we had earlier today. So I think I'll just reiterate some of that. I mean, we know timely access to care is essential to recovery. We know that people do recover, and that we know that deaths due to overdose and suicide are preventable. We also know that this access has the power to dramatically alter the trajectory of one living with or at risk of these conditions. We also know that for most, insurance holds the key. And New York State has successfully led many of the efforts to address some of the gaps in coverage, but there's more to do. Commissioner Sullivan spoke about some of the vestige practices and regulations that were rooted in stigma. We heard from Commissioner Cunningham about some of the racial disparities that are also baked into these rules and regulations. We also heard from Commissioner Cunningham about the importance of data, and we heard from our panelists about mechanisms for providers and consumers to be able to report information that would help guide the ability to investigate these matters and potentially provide more policy solutions, information for that. You know, and InUnity Alliance will make sure, and Rockefeller will make sure that we provide more details and information in collaboration with the agencies to make sure that you all have access to that ability to report. And then we'll continue to have discussions to advance these policy solutions. So we discussed issues related to direct access, but we also know that there are unnecessary burdens placing a strain on care providers, especially community-based providers, but with very limited resources that limit their ability to not only provide care, but also to expand the very services that are desperately needed. And last, they're also under the strain of a system that continues to provide reimbursement that is inadequate to cover care. And so we hope to continue having conversations to address these issues. And I want to thank all of you who are online and also in this room for joining us today for this important conversation. Thank you.